A very good evening and a warm welcome to all the revered dignitaries, attendees, and faculty to this webinar of Yuva ISOPAB being organized by the Gorakhpur chapter of ISOPAB and Gorakhpur Obs and Gynae Society. We always have the blessings of the ISOPAB head office, which is very encouraging and supportive in all the activities we do. Our regards to the central office bearers. Today, we are going to find solution to the challenges we face in our practice. And we have a galaxy of experts to help us out. Without much ado, I would like to invite Dr. Sadhana Gupta ma'am, our president of Gorakhpur chapter of ISOPAB, for her welcome address. Madam is the co-chair of CEFOG NCD committee. She has been the FOXY representative to CEFOG, also the vice president of FOXY 2016, ICOG governing council member, and has won award for the best council.
Okay, Amrita.
So, ma'am, over to you for your welcome address.
So, thank you, Amrita, and it is a great pleasure to once again welcome our ISOPAB president, Dr. Gangadhar Sahu, important for this another Yuva ISOPAB webinar series. So, why this Yuva ISOPAB webinar? It is fifth series what we are having, that for every professional organization, actually we have to look forward, and they must be given, their talent must be recognized, they have to be groomed for the future, and they have to be ready for the future the challenges of modern obstetrics. And I sincerely thank Dr. Gangadhar Sahu, Dr. Meena Samant, Dr. Pragya Chaudhary, that Gorakhpur chapter of ISOPAB has been given responsibility to having the first Yuva ISOPAB webinar, which we are going to have in Hotel Radisson View on 25th to 26th November. So I take this opportunity to invite everyone. It will have a different flavor. It will be responding to future challenges, present challenges, and mentors will be there to guide them and to sail them through all the issues, what the challenges we are facing as obstetrician gynecologists and as an obstetrical care people, along with the pediatrician as well as the radiologic and what our team of the healthcare system. So a warm welcome to everyone. My special regards to our chief guest, Dr. Gangadhar Sahu, guest of honor, Dr. Milind Shah, our Secretary General ISOPAB, Dr. Pragya, and all the speakers, dear close friends, Vijaya and Shashwati, Varevali, everyone who is there, and hearty thanks that you all have given time and always share your great academic and the skill input to the Yuva ISOPAB series. So once again, a very, very warm welcome to everyone, and we look forward to a great session today. So thank you very much, and Amrita, Ritu, you can go ahead to for the further proceeding.
Thank you, ma'am, for the warm words. Now I would like to invite all the dignitaries and the attendees for the lamp lighting. I would like to introduce a great teacher, a greater doctor, and even a great human being, greatest human being I know, Dr. Gangadhar Sahu. Gangadhar Sahu, sir, is the president ISOPAB. He's the retired professor and head of the department OBGY VSS Medical College, Burla. ex-Dean IMS and SUM Hospital Bhubaneswar, ex-Pro VC, SOA deemed to be University Bhubaneswar, a disciplined learner who never leaves any opportunity to learn, a passionate teacher who never feels taking attendance, a surgeon who pays respect to the tissues, an obstetrician who pays respect to 3 or more lives, mother, fetus, fetuses, and the obstetrician, a gynecologist who understands the physiology before pathology, a motivational speaker, preacher, a writer, a positive thinker, a philosopher, and an administrator. Overall, an extraordinary human being surrounded by ordinary disciples like us. So over to you, sir, for your blessings.
So I disagree with your last comment or the citation. Anyway, my namaskar to all of you. Thank you, Sadhana Madam, Amrita, my disciple, Dr. Milind, Pragya, and other stalwarts in obstetrics and gynecology, my favorite student Ojaswini, and all others. So I am overwhelmed to be a part of this Juba series. I feel by attending this Juba series webinar continuously, I am also feeling Juba younger and younger and younger. So that is a great blessing from your chapter, Amrita. So blessings from Lord Jagannath and Ma Samaleswari. Greetings from Aishopar. Now coming to few words regarding the Isopar for last 1 year. As you said, Isopar is now in a motion. Just we are reviving the Isopar into a different mode. So our the theme is let us walk the talk. That means work for the cause of Isopar, talk less. Second, regarding your chapter. So Gorakhpur chapter is one of the best chapters in Isopar, I can say. It is as vibrant as any other chapter. So always communicating with all Isoparbians through webinar, through personal contacts. Now Sadhana Madam is also in the vibrant mode to move from place to place. So I wish her all success for his journey in this life, in this part of life. So next is about this theme of challenges or complexities of modern obstetrics and their solutions. So I feel that we are rather sandwiched between the past obstetric practice and the future obstetric practice, what will be after 10 years. Yesterday, I was just attending a seminar on this. Past obstetric practice challenges were different because true obstetrics was there. The tricks of obstetrics were there. In future, what will happen? That is a different issue. But today, we are away from those tricks, maneuvers, practices of obstetrics. So why complexities are being developed? So complexities or challenges are mainly due to our fault of the society, fault of the mindset, fault of the obstetricians. Everybody, we are making it more difficult and complicated, and we are searching for a solution. It is said that whenever a challenge or problem is born, a solution is also born with that. You have to find it out. Only the patience is the key. So what are those challenges? Just within 2 minutes, I can say this much. But now actually, if you analyze the obstetrics itself, it is made easy. to ask any postgraduate student, the answer will be cesarean section. What will you do for this? Cesarean section. Ectopic pregnancy, cesarean section. At last, what is the most commonest indication for cesarean section? It is the pregnancy itself. So therefore, it is now obstetrics made easy. But what are the complications? But cesarean section is not out of danger. Gradually, we are creating complications because once a cesarean section, that scar comes. Second time, we are afraid of a VBAC. Now we are doing a repeat cesarean section. Cesarean section invites placenta to sit on the scar. That love between placenta and the scar, you know. So therefore, then comes your complexities. The panel discussion will be there. That is adherent placenta. So that will be there. And new thing has come that ectopic pregnancy can be on the scar. So therefore, cesarean scar pregnancy, that is another complexity. So who is creating these complexities? We, the obstetricians, are creating those complexities. And other complexities, now that you get married at 35 and you brand it as elderly primey, who is doing this? Your society is doing this. You yourself, the doctors are doing this. They are the most number one high risk pregnancy cases are the medical gynecologists or the doctors. So therefore, that is another thing. So we are adding diabetes, obesity, hypertension, everything to these. These are complexities that is being man-made. So how to solve it? The solution is very simple. Follow the normal biology of nature that has given to us. So 50% of solutions will be solved. A good, favorable nature, pay respect to the nature, control the population stabilization, then comes your practice. I think that will be more because once you go into the modern life cycle, IVF pregnancies will outnumber the normal pregnancies after 10 years. That is another complexity and challenge, how to face it. Therefore, my dear friends and respected persons who are attending this, so please do pay respect to the nature. Then follow the biology of human body or human life. Third, ethical practice of obstetrics will solve many more problems. For this, one important mantra is have a patience and patience and patience. That will solve most of your challenges and problems. Second, don't be miser to seek a second opinion. Anybody who is there, please take a second opinion for any challenges you face. And third and almost the last one is be God-loving. At any point of time, when you are in danger, then surrender before God. Oh God, I am with you. I have surrendered you. You save me. I am in danger. Thank you very much. Wish you all the best. Long live Isopor. Long live Isopor. Long live Isopor. I wish the Gorakhpur chapter all the best. And the President, Sadhana Madam, again wish her all the best as a presidential candidate 2023. And Amrita, love and blessings to you. Thank you very much. Thank you. Thank you.
Thank you, sir, for the wonderful words and your blessings. Our guest of honor is none other than Dr. Milind Shah, sir. He has been the president ISOPAB 2016 to 2018 at Solapur, president IMA Solapur branch 21-22, founder president of IHRF, honorary secretary general Asia Oceania Federation of Perinatal Societies, vice president Foxy in the year 2011, deputy secretary general in SARC, ex-chairman Rural Obstetrics Committee, managing committee member IAGE, ISAR, IFUMB, of Journal of OBGYN India, past steering committee member Asia Safe Abortion Partnership, past president Solapur Obs and Gynae Society. He has visited 2/3 of the world as a faculty and delivered lectures in various topics of obs and gynae, authored a book, Hypertensive Disorders in Pregnancy, Pelvic Organ Prolapse, and contributed more than 20 chapters in various books. He is also an active Rotarian. Over to you, sir, for your wonderful words and pearls of wisdom. Thank you, sir. Welcome.
Thank you very much, Dr. Amrita. It was such a generous and kind introduction. I'm really overwhelmed. But friends, when it comes to the ISOPAP, as Dr. Gangadhar Sahu said, certain people definitely has the ISOPAP to their heart. And that's how we want to do maximum, actually, whatever we can do for the ISOPAP. And now the ISOPAP is worldwide. It is not restricted to our country, because whenever we speak about ISOPAP in my FAOPS meetings as well, everyone respects India. Everyone respects actually ISOPAP with very high regards. And that's why I must congratulate the entire group of Gorakhpur OBGYN Society and the ISOPAP Chapter Society for this wonderful idea of encouraging the youngsters to be involved in the ISOPAP actually conferences in the ISOPAP platform. I must say big thanks to Dr. Sadhana and Amruta for this wonderful opportunity for having here and giving this honor. But definitely it's pleasure for me to listen to all those stalwarts who are very much here on these important aspects in clinical practice of obstetrics. Yes, the adherent placenta, the scar pregnancies are always dilemmas and need a multidisciplinary approach as well as the multiple opinions as well at times, because I have seen so many of rural patients who come to us from the rural Maharashtra also face a lot of problems when they face with these particular conditions. We advise them to be in the vicinity of the tertiary level care center where we can give justice to avoid all those problems related to the mortality, morbidity associated with this particular condition. I'm very sure that all the very eminent speakers are going to put a great height on that. So I must congratulate once again Gorakhpur Society for this very well organized conference and the webinar. Sadhana, wishing you all the best. I'm very sure you are going to take this message to entire actually the nation of saving women, and I'm very sure that will happen with the help of ISOPAB as well. Thank you very much for the invitation, and thanks a lot for these 2 minutes. Yes.
Thank you, sir. Thank you for the wonderful words and sparing your time. Our another guest of honor is Dr. Pragya Mishra, ma'am. Dr. Pragya Mishra, ma'am, is the General Secretary, ISOPAP. She has been the immediate past chairperson, Genetic and Fetal Medicine Committee. She is presently the consultant infertility specialist at New Life Test Baby Center and MGM Hospital and Research Center Private Limited, Patna. She is the founder secretary, Bihar chapter of ISAR. Secretary General she is of ISOPAP, Vice President, Patna Obs and Gynae Society. She has been conferred with many awards: Asia GCC Award, Healthcare Professional of the Year 2018, George Mahoney Award, CL Javeri Award, J. Mishra Gold Medal, 18th and 20th BoxCon, Dr. MP John Gold Medal in 13th BoxCon, and contributed chapters in 10 books and papers in national journals, organizing secretary of Foxy Ispat, organizing secretary of 24th BoxCon 2014. She is the scientific chairperson of ISOPAB annual conference. She was the scientific chairperson of ISOPAB annual conference in the year 2016. So over to you, Pragya ma'am, for your words.
I'm just trying to switch on my video.
Okay, ma'am.
Yeah.
Actually, there.
My internet.
Yes, she is there. Yes, ma'am.
Yeah, but I'm unable to switch. I'm trying to switch on my video.
Listen to you. We can listen to you, Pragya. So you go ahead and Saiti help her to get her video. Saiti, if that is not the issue, and you can go ahead, Dr. Pragya, with your address.
Yeah, sure. So Good evening to all the delegates and the organizing team. It is, first of all, I would like to
We lost her probably.
Seems
Ma'am,
that
you're muted.
it seems that it is net is like disturbed. That's why our video is not getting. Ritu, give a call a little bit so that we can go ahead with the scientific session. We welcome Dr. Sukanto Mishra. Thank you, Dr. Sukanto Mishra, was expert and a very, very senior isopharmacian. We welcome Dr. Himali Sinha, Dr. Shikha Seth, all experts and having a warm welcome.
Actually, it reminds me of Burla Sambalpur. I remember Rojaswin had organized such a wonderful event whereby we distributed pulse oximeters and trained the people for hypoxia management. And Vijayalakshmi also, I remember the Chennai, we had midterm CME during my presidential year. Wonderful event actually we had, and that's really a good moment. I think Pragnya must have been, stuck up somewhere.
Where is our net is issue? Actually, you distributed pulse oximeter before COVID, when people were not aware of pulse oximeter, and you see how it has come. And the
Exactly.
Ojaswini organizational capacity is something very
Yes.
focused and dedicated.
True.
Yes, Melinda.
I think
the
you
group-
can go ahead with the scientific section.
Yeah.
Madam,
Ritu,
there is
you
some
can go
network issue with her. There's some
so
network
please,
issue. The
please,
call is even not
please
being
go ahead,
received
go ahead, please.
because of. So should we start with?
Please go ahead.
Yeah. Please,
So we
please
are
go ahead.
quickly moving on to the scientific session, and the session anchor is Dr. Ritu Srivastava, Director of Savitri Clinic and Research Center, recipient of many gold medals, a very bright junior of mine. Over to you, Ritu.
Thank you very much, ma'am, for your kind words. Welcome all.
Congratulations, Ritu, for the words that have been showered on you by Amrita.
Welcome. A very good evening. Let's start with the scientific session. Session 1 is solution to challenges. And our two topics will be covered in this. First is GDM and another is car pregnancy. To grace the occasion, our experts are Dr. Shashwati Sanyal, Madam. She is Professor, Department of Obs Gynae, Guwahati Medical College. She is Chairperson, Medical Education Committee 2013-15, and Vice President, ISOPAP 2022. She is Chairperson, NEISAR, and Past President, GOGS, and immediate Past President, ISOPAP Assam Chapter. And Madam is member of editorial board also. We welcome you, ma'am. Then next, Dr. Sukanto Mishra, sir. He is professor and head of the department VIMS, RKMSP, Kolkata. He has been president 2015-16 in Bengal Obs Gynae Society. And he is founder president of Bengal chapter of Society of Vaginal Surgeons of India, and has many publications and is editor of WIMS. Next, Dr. Vijayalakshmi Shishadri, ma'am. She is senior consultant, Sundaram Medical Foundation, Chennai. She is president 2021, and she is member of Constitution Committee of ISOPAP, has won many awards and is chairperson of various committees. Then Dr. Shikha Seth. She is professor and HOD AIMS Gorakhpur and has been ex-professor IMS Greater Noida and UP University of Medical Sciences, CEFI, and has received many awards and has many publications. We welcome all of you. And now I request Dr. Shashwati to please introduce our first speaker, Dr. Ojaswini Patel, who will be speaking on GDM. Madam.
Thank you, Ritu. Good evening to all of you. Can I have the CV of Dr. Ojaswini Patel? Dr. Rajasini is very much known to me, and she's one of the very important worker of ISOPUB. At present, she is the Associate Professor cum Project Officer, PPC Department of OBGYN, Vimsar Burla. And she got number of awards. She's also co-executive member of East Zone Chairperson, ISOPUB, coordinator of ISOPUB Bulla Sambarpur chapter, and she has more than 20 original research articles, and her special interest is high-risk pregnancy and infertility. She has an excellent worker. I have seen her. She's an excellent worker and lots of knowledge. And her topic is GDM, and well, all of us know that GDM has become a kind of epidemic. When we were undergraduate students, we hardly used to get a case of GDM as an as in the examination. But nowadays, I think in a group, some of them we're definitely going to get a case of gestational diabetes mellitus because it is so rampant. So let us see what other things that she's going to tell us on this solution and challenges. Dr. Sini, over to you.
Dr. Pragya ma'am has joined.
Yes, Pragya, yes, Dr. Pragya, Jaswini, we take your permission and the chair, Dr. Shashwati, please, Dr. Pragya, we wish you to have your end. We wish to have your address.
I just want to add that, the topic that you have chosen for today, the theme, complexities of modern obstetrics, it's really the need of the hour, I must say. Because, well, we are doing a lot of modern obstetrics, but, it has its hazards and complexities. So really congratulate you, Dr. Sadhna Gupta, for having chosen the theme for today's Yuva ISOPUB webinar. So just hope that, you continue and keep coming up with the new topics. And the speakers also that you have chosen are they are very good speakers. I've heard them before. So I just wish you all the best for this CME. And apologies once again for this internet option problem which I was experiencing.
Thank you very much, ma'am.
You can carry on with the program.
Thank you, ma'am. I invite Dr. Jaswini Patel to begin her talk.
I must thank the organizer for giving me this opportunity. That's a.
So my namaskar to one and all. At the outset, I'm thankful to the organizer, especially Sadhna Madam, for giving me the opportunity. And I'm also thankful to all the chairpersons of this session. Special thanks to Shashwati Madam, who has introduced me to this forum. And my topic is GDM, Solutions to Challenges. As already Shashwati Madam has introduced this topic as one of the rapidly increasing numbers, so-called the epidemic. You can say it is a non-communicable disease which is rising like anything. So it is a disease which is full of challenges and full of dilemma. So I hope in the 15 minutes time, I can share some of my views in this disease. So there are so many challenges in this disease. Starting with the definition of
Jaswini, can you make it, excuse me, Jaswini, can you make it full screen? Make it
full screen, yeah. Make it full screen.
Make it full screen. This cup, yes. This cup sort of thing, click over.
Ma'am, kindly reshare it, ma'am, once again.
Madam, is it visible in full screen, madam? Madam, is it visible in full screen?
No, it is not full screen. No.
That's the wine glass. Yeah, wine glass.
They are telling that you have to reshare it. Something
yes, ma'am. Kindly reshare it, ma'am, again so that it will be coming as full screen.
Madam, is it now in full screen?
No.
Yes,
Yes.
ma'am.
Now it is now, yes.
Now it is.
Now it is
it
full
is.
screen.
You are.
Okay, madam. So GDM is one of the common medical condition, common endocrine condition, having full of challenges to deal with. So I'll discuss something about these challenges. So there are so many challenges starting from the definition, the screening, whether we have to go for a routine screening or selective screening, or the timing, whether we should go for a one-step or two-step method. And in the one-step and two-step also, if we are doing the GCT, that's the glucose challenge test, whether we give the 50 grams glucose or 75 grams glucose. And when we are doing the OGTT, whether we give the 75 grams glucose or 100 grams glucose, and whether we have to take the plasma glucose or the whole blood glucose, because sometimes in the plasma glucose, the glucose value is little higher compared to the whole blood glucose. And which classification we should adopt. And there are different values in the different types of classification, different types of organizations. They have given different types of limits for the cutoff values for the diagnosis or the screening of the GDM. What is the targets? What blood glucose level should be our targets for to say it is controlled? And whether we have to adopt the self-glucose monitoring or the patient has to visit the clinic for multiple times for the glucose monitoring. So the self-glucose monitoring is commonly advocated, and the patient should use a standardized glucometer to test her glucose value from the capillary blood. And she should, now there are so many challenges regarding whether it should be intermittent self-monitoring or there is a subcutaneous continuous glucose monitoring device. Whether that we should treat her with the oral hypoglycemic agent or with insulin, or and if we are using the insulin, what type and what dose should be used, and whether we should give the multiple injection or continuous insulin pump. So combined subcutaneous continuous glucose monitoring device and continuous insulin pump is told as the artificial pancreas. This is just maintaining the glucose level continuously, monitoring the glucose level continuously. But this is just avoiding the undetected hypo or hyperglycemia. But there is no extra benefit as far as the long-term and the short-term complications or the management is there. Then how we have to go for the postpartum screening and follow-up. So coming to the definition, the gestational diabetes mellitus is defined as carbohydrate intolerance of variable severity with onset or fast recognition during the pregnancy, according to the COG. But according to the American Diabetic Association, it is defined as diabetes diagnosed during pregnancy that is not clearly overt. So that means what is overt? So overt diabetes, according to IAD-PSD or ADA, IAD-PSD is the International Association of Diabetes in Pregnancy Study Group. So overt diabetes in pregnancy is there when the fasting blood glucose is more or equal to 126, HbA1c is more or equal to 6.5%, and random blood glucose is more or equal to 200 milligram per deciliter. So this is the blood parameters. But sometimes we can get the clear florid pictures of diabetes, even in the first times in the form of polyuria, polydipsia, polyphagia, or if she has presented ketoacidosis or there is certain retinopathy or nephropathy, that we have to think of overt diabetes. Worldwide, it is rising like anything. 1 in 10 pregnancies is associated with diabetes, and 90% of them are GDM. And undiagnosed and inadequately treated GDM can lead to significant maternal and fetal complications. Women with GDM and their offsprings are at increased risk of developing type 2 diabetes mellitus later in life, and also some of the other syndrome or other metabolic X syndrome like the heart disease, the abnormal lipid profile, and obesity.
I
Is
think
there a
some internet
problem?
issue or what?
Yeah. Can't hear her. Can somebody call her and say that?
Yes, ma'am. I'm calling her.
She's back.
Okay,
Yes,
that's
ma'am.
right.
So sorry for Am I audible, madam, now?
Very
Yeah,
much.
yeah.
Yes, ma'am.
Yes, ma'am. Was just calling you.
Please make it full screen. Dr. Ojaswini.
So, yes, sir.
You go to the wine goblet below. Yes, that's it.
Okay. Is it now in full screen?
No, actually, we cannot see. And
Yeah,
now
yes.
it is, yes.
Now.
Yes.
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 Please carry on. Yeah.
So as it is rising like anything throughout the world, India is not exempted from this. So as for 2010, India, 22 million women with diabetes in the age group of 20 to 39 are there. And so many more are there as the impaired glucose tolerance cases. In view of the high prevalence of the GTM in India, Indian women, Government of India has released national guidelines for diagnosis and management of gestational diabetes matters in December 2014. So coming to pathophysiology, GDM is characterized by hyperinsulinemia and insulin resistance. And we all of us know that pregnancy is a diabetogenic state. In the first trimester and in the early second trimester, there is increased insulin release due to high level of estrogen. But the late second and early third trimester, there will be insulin resistance because of so many antagonistic hormones. And the baby in utero is exposed to a hyperglycemic environment. And the baby not only will be affected during pregnancy, but in the later life also, because of the intrauterine imprinting of this hyperglycemic environment, the baby will suffer so many morbid diseases later on. So coming to the implications of the diabetes in pregnancy, the risk of serious injury at birth is doubled. The likelihood of cesarean delivery is tripled. The incidence of neonatal intensive care unit admission is quadrupled. So pregnancy and diabetes, there is a vicious cycle. During pregnancy, the pregnancy is a diabetogenic state. So if there is pregnancy, the hidden diabetes is manifested. And when the patient becomes diabetic during pregnancy, in the future life also, there is 50% chance of this woman becoming diabetic in the next 20 years. And both can affect to each other. Pregnancy can affect to diabetes, and diabetes may also affect the pregnancy. So what are the effects of pregnancy on diabetes? During pregnancy, there is altered carbohydrate metabolism and impaired insulin action. Insulin requirement increases as pregnancy advances. So we have to know that gradually insulin requirement increases as pregnancy advances. During pregnancy, there are so many physiological changes in the carbohydrate metabolism. One is the fasting hypoglycemia, postprandial hyperglycemia, accelerated starvation, and ketosis-prone environment. So same glucose level. In the non-pregnant state, the patient may not have a ketoacidosis, but during pregnancy, she might develop ketoacidosis. So effects of diabetes on pregnancy, there will be respiratory distress syndrome to the newborn, polyhydramnios, fetal macrosomia, different injuries to the baby, abortion, IUD, and after childbirth also, there will be neonatal hyperbilirubinemia, and there might be so many congenital malformations, especially in the ovate variety. So this hyperglycemia had different effects on the different system, and because the decreased cortisol production may lead to the decreased surfactant synthesis, leading to respiratory distress syndrome. The fetal hyperglycemia may cause polyhydramnios. Fetal hyperinsulinemia may cause fetal macrosomia, and because of this macrosomia, there will be so many labor problems in the form of shoulder dystocia, obstructed labor, and increased rate of cesarean section. So hyperglycemia in the first trimester, there will be impaired organogenesis leading to multiple congenital malformations, and also fetal hyperglycemia may cause certain unexplained or the sudden IUD because of the lactic acidosis. And after childbirth, there is also higher risk of the hyperbilirubinemia because of the polycythemia and RBC breakdown. So many risk factors are there, but I am not going to cite all the risk factors. We Indians are Asian in ethnicity. So Asian population is high risk case. So we have, all of us are diabetic prone. So many maternal complications during pregnancy that I've already.
I think we missed her again.
Doing some issues are there. We can't hear you, Ojashini.
She's trying.
A lot of, I think it is due to heat or something, a lot of internet issues are seeming. We can ask with Dr. Sukanto, what is your takeaway? I think we can roll out the discussion about about how we can diagnose, like in Indian setting, what is your message, all the chairpersons, yes.
At the outset, I would like to thank Dr. Sadhana Gupta, my friend, and of course, Dr. Amrita, for inviting me to participate in this beautiful academic journey of ours. So it's going on. And I'd also like to thank Dr. Sashwati Sandal Chaudhary for introducing me. And of course, Dr. Ojasin has started a brilliant talk. Unfortunately, the internet issue has become a problem. Now, regarding, am I audible?
Yes.
Yes, sir.
Yes.
Yes.
And now regarding the definition, there's always an issue. Like, yes, we certainly have created one cutoff point, and then we can diagnose for those who are euglycemic at the beginning. Now, those who are diabetic even before pregnancy, call them over diabetes. That's clear. But some of them are not over diabetic, not diagnosed before pregnancy, but diagnosed for the first time during pregnancy. Basically, they are over diabetes. Should we call them GDM? That's one issue. Am I clear? So according to the definition that's being popular, that they should be considered as GDM. This is one complexity. Second is, of course, regarding the prevalence of the disease. Now, it entirely depends on which cutoff criteria is being utilized to make the diagnosis. Now, the prevalence, again, varies to a large extent according to the work of Dr. Sesaya, whether you are dealing with the rural people or the urban people, and of course, the methodology that's being utilized. Now, WHO, Government of India 2018, I mean, that's the latest guideline, and Deep Sea Protocol are more or less same with little variation. IADPSG criteria are a little different, published in 2008. Now, what is all about this? Basically, screening is considered for a particular disease when we find that the disease is pretty prevalent. It can cause certain problems, certain adverse effects, and the treatment of those adverse effects are there, and it's preventably you can diagnose the disease. It's done in 2 steps, and that's how the process starts. In fact, that the adverse effect of diabetes on pregnancy was noted as early as 1964, when O'Sullivan and Mohan has devised this OGTT method. And the idea was not primarily to detect the complications at that point of time, but also to decide the diagnosis of GDM after 8 years. But gradually we came to know it also has an effects during pregnancy for the baby. Now, we know that the importance also lies in the fact that if we treat them, not only we can avoid the complications of pregnancy, the bad effects on the baby, but also we can probably delay the onset of diabetes on the mother and also on the baby. So it basically takes care of 2 individuals and 2 generations. So that's the importance of GDM. Now, looking at the prevalence of the disease, nowadays we all know that it's considered, diabetes is considered as a very much pandemic disease. In fact, India has become a capital of diabetes, and it is become so much prevalent nowadays, as Dr. Sashwati was mentioning, that yes, during exam every day 1 or 2 cases of GDM will be there to the postgraduate students. And that's because there are many reasons, not only the diet, socioeconomic status, the elderly age of the patients, but overall, the diagnosis and awareness has also become important. In the meantime, one very important study, we all know that HAPO study, that is hyperglycemia and
Ojaswini, thank you, sir. Actually, so I would like to have Vijaya comment about it, because I just visited the Kerala Federation. So they are having the different protocol, and that has been supported by the Kerala Federation. That is glycolated hemoglobin in first trimester and always glucose tolerance in all the 3 trimesters. So Vijaya, what is your takeaway? And Ojaswini, you start screen sharing before we again lose your connect. Unmute. Thank you,
I
sir.
think let Ojaswini present, as she has some.
she has come. Let her present first.
Let her first.
Ojaswini, be quick. Yes, be quick before we again lose.
Yes.
Yes, Dr. Ojaswini, please start.
Yes, sir. So as I was telling about the pregnancy, effects of pregnancy on diabetes. So there is so many abnormality occurs. There is fasting hypoglycemia, postprandial hyperglycemia, accelerated starvation, and the ketosis prone condition, pregnancy ketosis prone condition. And also aggravates the vascular changes in the retinopathy, nephropathy, many things are aggravated. During pregnancy, the diabetes has many effects on the mother and the fetus that I have already described. So there are so many classifications that are there, but the old classification is the Priscilla-White classification, where the diabetes was divided into 2 types: the pre-gestational and the gestational. The gestational is the class A. It is again A1 and A2, whether it is controlled by diet or it needs medications to control. And there are other classes are there according to the age of onset and the duration of the illness and the different types of organ involved. So, what is the scenario in India about the screening? The DIPSI guidelines mostly we are following the DIPSI guidelines. So where 75 grams of the glucose is taken irrespective of the diet, and after that 2 hours of ingestion of this glucose, the glucose is estimated, the blood glucose is estimated. And if it is more or equal to 140 milligram per deciliter, the cutoff is 140. We will say at GDM, if it is more or equal to 120 but less than 140, this decreased glucose, decreased gestational glucose tolerance, and more or equal to 200, it is diabetes. And we have to follow all the pregnant women should be screened for the diabetes. So we are following the universal screening. If in the first trimester, whenever the patient comes for antenatal checkup, as early as possible, we have to do the screening. And if it's negative, we have to repeat it at 24 to 28 days. Because you know, the diabetogenic state is more and more towards the later part of the pregnancy. So we have to screen again at 24 to 28 weeks. So how to test? There is 75 gram oral glucose is mixed with 300 ml of water. And especially the diet, it is the blood sugar is estimated after 2 hours of the ingestion of the glucose. So all women should be screened. And if it is glucose is more or equal to 140, it is managed at GTM as per the guidelines. If it is less than 140, repeat the test at 24 to 28 weeks. If it at 24 to 28 weeks is positive, it is again more than 140 or equal to 140, then we have to manage like the GTM, or less than 140, you have to manage like the normal antenatal testing. So what are the antenatal care we have to follow in case of the GDM? All GDM patients are managed in a multidisciplinary approach, like for the involvement of the obstetrician, diabetologist, specialist, midwife, pediatrician, and dietitian. All women should receive dietary instruction with individual recommendations based on the weight and height. Daily calorie needs should be made of approximately 40% carbohydrate, 20% protein, and 40% fat, of which less than 10% should be saturated fat. And when the patients are coming with the GDM, first we have to give the medical nutrition therapy, the diet plan. And after 2 weeks of the diet plan, we have to again do the test. The 2-hour postprandial blood glucose is less than 120. You have to continue the medical nutrition therapy because it is responding. If it is more or equal to 120, have to go for the insulin therapy. And even if with the medical intuition therapy, you have to monitor her again. So up to 28 weeks, we have to call her for the antenatal checkup once in 2 weeks, and after 28 weeks, once in a week. And if she's receiving the insulin, then we have to monitor the fasting blood glucose and 2-hour postprandial glucose every 3rd day or more frequently till insulin dose adjusted to maintain normal plasma glucose levels. And we have to monitor the 2-hour postprandial blood glucose once weekly. So in the medical nutrition therapy, we have to give the diet plan in such a manner that the half portion of the thali should contain vegetables, cooked as well as raw, and there should be 1 serving of fruits. There should be dairy product 1 serving in a day, and other quarters, that is 1/4 should be containing cereals and 1/4 should be containing proteins rich foods. And the foods should be small amount and frequent food. So there should be 3 to 4 main meals and again 2 to 3 snacks. It will be divided into multiple times. So the diet therapy is, our goal is to avoid ketosis, achieve the normal blood glucose level, obtain proper nutrition and gain weight appropriately. The amount and distribution of the carbohydrates should be based on the clinical outcome measures. But a minimum of 175 grams of carbohydrate per day should be provided, and this should be given in 5 to 7 meals and snacks. And use of low glycemic index diets decreases the need for insulin to maintain the euglycemia. And the calorie need is different from the different BMI women. And if the BMI is more and more, you have to give less of calorie. So exercise is also needed along with the medical nutrition therapy. So exercise should be a moderate level exercise, at least 30 minutes per day. It should be there, and it should be aerobic exercise. The role of OHA. So there are so many controversies regarding the role of OHA, because oral hypoglycemic agents are commonly not used, but sometimes the metformin and the glyburide, they can be used. So there are, according to the SCOG, it has been shown that the metformin and the glyburide have been used successfully in GDM, but not currently recommended for overt diabetes except for limited and individualized use. And in the OHA, the metformin and glyburide both are having almost equal type of response. But this thing is that these 2 molecules can cross the placenta, but less so in the glyburide. And it has been seen that the metformin, with the use of metformin, there is also the higher need of insulin compared to glyburide. This is the study in the different case studies. But the patient who are PCOS and they were taking metformin, it should be continued till 28 weeks to prevent diabetes. So coming to the use of insulin, so after the 2 weeks of the medical nutrition therapy, if the blood glucose is more or equal to 120, the 2-hour PG is more than 120, then we have to start the insulin. The insulin is better to start the mixed form. There is the intermediate acting insulin and the long acting insulin combined form, and it is injected in the subcutaneous injection before breakfast once a day, or if the dose is higher, it can be divided into 2 doses. So 2/3 should be in the before breakfast and 1/3 should be before dinner. And with the use of insulin, again, you have to do the blood glucose estimation every 3rd day. If the blood glucose is not controlled, it is rising, it is between 120 to 160, we have to give the insulin dose is 4 units, between 160 to 206 units and more than 208 units. But if the fasting plasma glucose is corrected by the insulin, then we have to adjust in the same dose. But if this is not being corrected, remaining higher side, then we have to increase the dose. And our target is the fasting plasma should be less than 95 and 2-hour PPPG should be less than 120. And if the nutrition therapy with the use of insulin, if the glucose level less than 120, we have to continue the same dose of the insulin. So coming to the role of ultrasound, so it's preferably done in the first trimester to confirm the gestational age by dates, and the anomaly scan should be done definitely. And it's particularly important when there is overt diabetes or HbA1c is highly elevated, more than 6.5, and to also do the fetal echo at 20 to 24 weeks, because cardiac malformation is most common, but it's not so common in the GDM as compared to the overt diabetes. And we have to do the growth scan in the different gestational age at 30 to 32 weeks, at 36 to 38 weeks, to know about the fetal size, amniotic fluid index, and to help ascertain the mode of delivery. And this ultrasound will also helps in other parameters to monitor the fetal biophysical profile. Then coming to the time and mode of delivery. So GDM, which is controlled with diet alone, there is no complications, then they can be delivered at 40 weeks. But GDM controlled with insulin or OHA should be delivered at 38 weeks. But if there is certain other complications with this diabetes, then we have to plan accordingly. We might deliver before 38 weeks also if there is complications to the mother and to the fetus. So diabetes itself is not an indication for cesarean section. Pregnant women with diabetes who have normally grown fetus should be offered elective birth through induction of labor or by elective C-section if indicated after 38 completed weeks. But if there is macrosomia is there, then we can go for the elective cesarean section. But compared to non-diabetic macrosomia, in case of the diabetic macrosomia, there is higher risk of the shoulder dystocia because of preferential deposition of fat over the shoulders. Then comes the post-delivery follow-up. So women with GDM are at higher risk of the type 2 diabetes mellitus later on in the life. The maternal glucose levels usually return to normal after delivery. GDM cases are not discharged after 48 hours, unlike other cases, and we have to do the blood sugar, the fasting plasma glucose, and the 2-hour postprandial glucose before discharging the patient. And subsequently, you can do the 75 gram GTT at 6 weeks postpartum. And at 6 weeks, there are different cutoff values are there. The fasting plasma glucose is remaining more or equal to 126. She is a full-blown diabetic. And 75 gram OGTT 2-hour plasma glucose normally is less than 140, but the impaired glucose tolerance is 140 to 199, and diabetes is more than 200. So during pregnancy, the target blood glucose values are according to SCOG. The fasting plasma glucose should be less or equal to 95. The preprandial glucose should be less than 100. 1 hour postprandial should be less than 140. 2 hour postprandial should be less than 120. And glycosylated hemoglobin should be less or equal to 6%. But there are different values are there for the different organisms. So management during labor, morning dose of insulin is omitted, but the night dose was given as usual dose. During the labor process, the aim of the blood glucose is around 100. We have to keep the blood glucose around 100. So we have to start the normal saline IV fluid, and we have to monitor the blood glucose every 1 to 2 hourly. The blood glucose is more than 100, then you can start the insulin. And the insulin dose depends upon the level of the blood glucose. So if it is 90 to 126, 1 unit per hour, 126 to 180. So like this. But in the labor, the insulin that is given is the soluble insulin or the regular insulin, which is dissolved in the 5% expo. And to monitor the vitals and fluid intake and output chart, urinary ketones and the blood glucose level. And the fetus is also dangerous. You have to monitor the fetus continuously, and the partograph has to be charted preferably. That should be labor analgesia. And as because that is a big baby, there is high chance of this PPH, and we should be prepared for that. And the baby is to be cared by the neonatologist. And in the postpartum period, the hyperglycemia rapidly resolves soon after childbirth. So it is reasonable to measure a single random or fasting blood glucose level before discharge from the hospital. And postpartum glucose tolerance testing is important for women who have GDM, because we know there is a higher risk of this 7-fold increased risk of the type 2 diabetes mellitus. At 6 to 12 weeks postpartum, only 1/3 of women with persistent glucose tolerance have an abnormal fasting blood glucose level. Therefore, to detect all women with glucose intolerance, 75 gram OGTT is done at 6 weeks postpartum. And later, at least it should be repeated every 3 yearly according to SCOG. Even if it is found normal, every 3 yearly it is repeated till lifelong. So coming to the summary, universal testing of all pregnant women for GDM, testing recommended twice in pregnancy at first antenatal visit and then at 24 to 28 weeks of gestation. Single step 75 gram 2-hour postprandial glucose test is performed. There is a DIPSI guidelines, and if it is more than or equal to 140, then we have to think in the line of GDM, and we have to start the medical nutrition therapy along with the exercise. And with the medical nutrition therapy, if the blood glucose is remaining still more than 120, then you have to start the insulin therapy. And the women should be monitored by 2-hour PPBS throughout the pregnancy. Antenatal visits should be 2 weekly in the second trimester and weekly in the third trimester. And pregnant women on insulin therapy with uncontrolled blood glucose levels, that is more than or equal to 120 milligram per deciliter to our postprandial blood glucose. The insulin requirement more than 20 units per day. They should be referred to a center where comprehensive emergency obstetric care is available. And GDM pregnancy is associated with the delay in long maturity of the fetus. So routine delivery prior to 39 weeks is not recommended. In some situations that can be done. And vaginal delivery is preferred, but LSS is done only for obstetric indication. And postpartum evaluation should be done there. Thank you all for patient hearing.
Thank you very much, ma'am, for the precise talk on GDM. Now I would request Dr. Vijayalakshmi Sheshadri, ma'am, to please introduce our second speaker. The topic is car pregnancy and the speaker is Dr. Binu Kushpa.
Thank you, Amrita, for that wonderful introduction and inviting me, Dr. Sadhna. Of course,
I think
Sadhna, before I proceed.
Yeah, I think before going to, yes.
Before I proceed to the next, this thing, what you had asked about HbA1c. See, here we are, of course, following Professor Seshaya's DIPSI guidelines, where we are doing 2 hour 75 grams glucose for screening. But yes, we can do a routine OGTT in suspicious cases. As far as HbA1c is concerned, what has been predicted and what has been thought of and concluded that if you keep HbA1c in the first trimester as 6.5, possibility is definitely that there could be some fetal anomalies in the beginning itself, because it could be that when she conceived itself, she had a very high blood glucose levels, because HbA1c, a little higher HbA1c definitely predicts the beta cell disorganization and malfunction. And that is why this is thought. But it does have a great value in predicting which of the population is going to go in for GDM. But it does not, however, reflect any evident truth when we are doing HbA1c in the second and the third trimester. The reason being the hemoglobin itself drops because of the hyperemia of pregnancy in second and third trimester, and the relevance of HbA1c, the sensitivity and the specificity of HbA1c as a predictor goes down in second and third trimester. And if you really want to take HbA1c as a cornerstone for prediction of the sensitive population which is going to go in for GDM, the levels have been brought down to 5.7. And in fact, if you are directly doing, see, somebody directly presents to us as third trimester and are going to predict, it can be even brought down to 4.6. And that is the importance of HbA1c if you are going to do in the second and the third trimester. But the best really usefulness of HbA1c will come in the first trimester for the overt diabetes or the pre-diabetes, and of course to predict the fetal anomalies. And we have seen somebody starts with a very high HbA1c, even we have seen 11, 14, and though we are always scared that these are the patients, not just that they will be developing diabetes, but they will be developing anomalous fetus. But what happens, many of them go in for miscarriages or miscarriages. This is probably the nature's way to deal with these abnormal fetuses. And therefore, HbA1c in the first trimester is useful. And if you bring down the levels further from 6.5, of course, is almost a predictor for anomaly. But if it is 6 or even brought down further to 5.7 or to 4.6 in the third trimester, the specificity might increase and we might get some clue that these are the patients. Otherwise, only the significance is in the first trimester, because anyway, we are going to diagnose GDM by other means later. And as Ojaswini said, that was a wonderful lecture, Ojaswini, covering a big mammoth topic of GDM in a short time. And as she said, we go ahead testing first in the first visit and then in the 26 or 24, 28 weeks, whatever, depending on your this. And we know in Chennai, we are really every third, fourth patient is a GDM patient, diabetic patient. So we keep doing all these things, all these exercises, and Professor Shaya with his guidance, of course, is doing a wonderful job all the time. And probably we will be getting more guidance from him in recent years too. That is what is about HbA1c, Sadhna.
Yes. Thank you very much, because this is the thing, what you say, that the first trimester, it can be screening test. That patient was already in the diabetic, like she was diabetic, but in second and third trimester, we have to have the limited value. Thank you, Vijaya, for wonderful, and congratulate Ojaswini for a very concise and clear, and your thalis and everything. And though the internet was interrupted, but I think in the mind we could keep the continuity. So congratulations, Ojaswini. So Ritu, you can go ahead.
Yeah. So over to my
you.
assigned
Thank you.
job of introducing Dr. Bino. Yeah, can I have her CV, please? In fact, I thank Sadhna for this wonderful opportunity. She has been my friend, I think, from the days when I contested against her for the Safe Motherhood Committee chairperson. She was noble enough because I lost to her, and she made me the South Zone chairperson, South Zone coordinator for the Safe Motherhood Committee. Thank you, Sadhna. You moved ahead further in Foxy, and I wish you all the best for the presidential election as well. Now I move on to introducing Binu Kushwaha Singh, who is Professor and Head Department of OB-GYN at REVA. And of course, she has been awarded amply by the IJOG, and has also received Dr. Kamini Rao Oration for the year 2015. Young gynecologist, looks very promising. And let us hear from her. And of course, there is one big mark said that she did country's first out of OT resuscitative hysterotomy with positive feto-maternal outcome. That's wonderful to hear, and probably it has some relevance to her topic, which is scar pregnancy. And as Professor Sahu said, the scar pregnancies are rising and are going to rise because of the increase in the number of cesarean sections that are happening. So further pregnancies happening in the scar is going to be really rampant, and we have to be well aware of what happens in scar pregnancy and how do we manage these scar pregnancies. So over to Binu for a wonderful talk that we are anticipating to hear from her. Yes.
Thank you so much, ma'am. Thank you so much. First of all, I would like to thank Gorakhpur Society, especially Sadhna Gupta ma'am, for giving me this opportunity. I'm very grateful to her. So I would now share my screen. Give me a moment. Is it visible now?
Yes, ma'am.
Yeah.
Just make it full screen.
Yeah, sure, ma'am, sure. So good evening, everyone. Good evening, everyone. My talk is on scar pregnancy. So as we all know that scar pregnancy is a type of, just a second. Yeah. So as we all know that scar pregnancy is a type of ectopic pregnancy where the embryo is fully or partially implanted in the muscle or fibrous tissue at previous cesarean scar site or any other scar site, like scar caused by myomectomy or other surgeries also. The incidence of cesarean scar pregnancy ranges from 1:1800 to 1:2500 of all pregnancies. And if we talk about the ectopic pregnancies, it constitutes around 6.1% of all ectopic pregnancies. The increase in incidence of CSP, we all know, has been due to primarily in the incidence of cesarean section itself, and yes, also due to the advancement in imaging modalities that we have that diagnoses this condition early in pregnancy. So what is the etiopathogenesis of scar pregnancy? For that, we should first understand the physiology of normal implantation. So in a normal pregnancy, there is an implantation of blastocyst, which causes modification of endometrial stromal cells and which further enhances decidualization. This decidualization in turn regulates endometrial receptivity to cause changes in immune and vascular cell function and resulting in architectural changes and further tropoplastic invasion. In normal pregnancy, this tropoblast invasion goes up to decidua bacillus, and there is a one more layer after that, that is the zone of fibrinoid degeneration. So this invasion does not go beyond this fibrinoid degeneration layer. But what happens in a scar pregnancy? So this prior scar results in absence or partial disruption of decidua bacillus and absence of fibrinoid layer. So the blastocyst gets embedded in fibrous scar tissue and myometrium. So endometrial and myometrial disruption or scarring is the main predisposing factor for abnormal pregnancy implantation here, and which is due to the post-caesarean scar defect or scar caused by other interventions also. If we talk about the risk factor, presence of a previous scar is a must. It is an essential factor. Along with that, this risk increases multifolds with poor wound healing. And poor wound healing may be caused by many things like gravidity, parity, and the number of induced abortions after the cesarean section or any other scar if she already has. Or literature says that a history of cesarean section performed at a rural hospital because the techniques they use are not very good. So the apposition of scar or apposition of the layer of the uterus is not very good. And also infection rate over there is high. So there is a poor wound healing. And then there is, if there is short intervals between the present and the last pregnancy, this also increases the chances of scar pregnancy. It has been said that the retroflexed uterus, due to there is a tension over the anterior wall of the uterus, so it causes poor wound healing again. So retroflexed uterus is a high risk factor to cause scar pregnancy, and also the presence of multiple pregnancies in index pregnancy, in present pregnancy. So in pregnancy after the cesarean section. So there has been an association mentioned about the type or method of C-section which was used in prior pregnancy. That also increases the risk of scar pregnancy. So elective C-section itself is a risk factor for post-cesarean scar defects, especially if this elective cesarean section is performed before the first stage of labor and in an undeveloped lower uterine segment. Here, the cesarean incision site may be imprecise, so that may result further in poor wound healing. Also, performing C-section during advanced labor also has been associated with an increased risk of incomplete healing of the uterine incision. So too early or too late cesarean section, both are the high risk factors for causing scar pregnancy in next pregnancy. So as I said, presence of a multiple C-section also increases the risk. And yes, single layer closure. This is a big thing that we need to teach our juniors, that single layer closure in primary cesarean section is not to be done these days. It has been proven that it increases the risk of scar pregnancy in next pregnancy. So what is the clinical presentation of scar pregnancy? Most of the times these patients are asymptomatic, or she may present with slight bleeding and abdominal discomfort, and she may also present with acute pain and profuse vaginal bleeding. There are as such no signs or symptoms which are pathognomic of cesarean scar pregnancy, and the diagnosis is primarily based on USG findings. So if we come to the diagnosis of the scar pregnancy, studies indicate that cesarean scar pregnancy can be detected by USG as early as between day 33 and 94 of pregnancy. And in fact, the diagnosis is easier to be made in early pregnancy scan, and that has to be a transvaginal scan. It is also suggested that early pregnancy USG in patients after a cesarean section should be conducted with a high frequency probe, as they are optimal for cesarean scar pregnancy detection. Doppler examination is very significant here because it tells you about the qualitative, also the quantitative vascularization of the site of implantation. Then USG Doppler characteristics. There are certain criteria on the basis of which we make the diagnosis of scar pregnancy. If we talk about the USG, it is basically the empty upper uterine cavity along with the closed and empty cervical canal also, because the main DD is with the cervical pregnancy. So cervical canal should be closed and the upper uterine cavity should be empty. Then here gestational sac gets embedded at cesarean scar site. Then the layering between this sac and the outer layers is less than 5 mm, or the myometrial layer altogether may be absent, and the pregnancy directly gets embedded at the peritoneum or touching the bladder. And a very important thing, that there is a negative sliding sign, because the second very important DD of scar pregnancy is inevitable abortion. When the abortion is in process and the sac is lying in the lower part of uterus, then you may get confused it with a scar pregnancy. So for that, there is a method. Then when we do a TVS, we move that TVS probe, right? So it does not cause the movement of the sac in case of a scar pregnancy, but it would be moving in case of an inevitable abortion. And then if you put Doppler, then of course in a scar pregnancy you would see lots of vascularization, but not in cases of inevitable abortion. Doppler, as I said, it tells about the vascularization. Here the flow is high velocity and low impedance, and there is a specific method these days, they call it VOCAL, virtual organ computer aided analysis. It actually helps in the quantification of this uterine neovascularization, and it is very helpful after the treatment. If you have used a conservative treatment, so to follow the quantity of the blood flow to that scar site pregnancy is to be followed by this method accurately. Then these are the USG and Doppler pictures of cesarean scar pregnancy. As you can see, there is an empty upper uterine cavity. There is empty cervical canal, and mass is placed. This G-sac is placed anteriorly, low in uterine cavity, anteriorly. And the myometrium would be very thin, mostly less than 3 mm. And if we put Doppler, there would be lots of blood flow around this G-sac. Then the DD, the differentiation from early intrauterine pregnancy itself. The G-sac of a early intrauterine pregnancy may get implanted at the lower part of the uterine cavity, but not that much lower that it gets implanted on the scar site. Here also you may get confused. So there is a radiological method to detect these kind of pregnancy. You put two perpendicular lines. First one is from the fundus till the internal os, and second one, which is shown as interrupted yellow line here, is an imaginary line which divides uterus in sagittal section in two portions. So by these two perpendicular line, uterus is divided into 4 quadrants, right? So in case of scar pregnancy, the upper 2 quadrants would be empty. So the sac would be placed below this yellow line and implanted at the level of C-section scar. And less than 2/3 of the superior inferior diameter of gestational sac would be lying below the blue line. So this is a very good method to differentiate a low-lying intrauterine pregnancy from a scar pregnancy. And of course, the myometrial thickness would be less than 5 mm. Then the role of 3D USG and MRI. So generally for the diagnosis of scar pregnancy, they are not required. It is only when there is a confusion regarding the diagnosis, especially if the scar pregnancy is lying in posterior part. There is a posterior implantation. Maybe some sharp curettage has been done in previous pregnancy, or the myomectomy has been done posteriorly. So if this sac gets embedded posteriorly, then there may be a problem in detecting these scar pregnancies by normal USG. So we do either a 3D USG or an MRI to detect these cases and to see the extent of invasion in type 2 scar pregnancy. We would be talking about the types of scar pregnancy. Basically, type 2 is when it goes towards the bladder and it may penetrate through the uterine wall. So in those cases, to just know about the difficulty of the surgery that we are going to have to prognosticate the case, we may order an MRI. That would be very helpful. 3D Doppler more useful in further monitoring. That I said, the vocal method that is useful for monitoring after the conservative treatment. DD, I already talked about. Cervical pregnancy and inevitable abortion are the main DDs. Cervical pregnancy, how we rule out that? Here the cervix is ballooned out. The sac is lying in cervix, right? And the internal os would be closed. Doppler flow around this pregnancy would be very good, but the negative sliding sign would be negative here to differentiate it from the inevitable abortion, where the sliding organ sign would be positive and there would be no flow around the inevitable abortion. Then these are the pictures. This is the cervical pregnancy where the sac fully lying in cervical canal. The os is closed and cervix is ballooned up. There is a very good blood flow around the sac, and this is the inevitable abortion. As you see, this is an irregular crumpled sac and with no or minimal blood flow. So these two are the main DDs which we need to keep in mind. So what are the classification? What are the types of cesarean scar pregnancy? There are basically two types, type 1 and type 2. Type 1 is when the pregnancy goes towards the uterine cavity or towards the cervicoischemic region. Here myometrium is thin, but still the pregnancy is going inside the uterus. Implantation, of course, is at scar site. Main thing that we need to know is there are lesser chances of early rupture of that scar site. So here we can think of conservative management in these patients. This is also called as endogenic cesarean scar pregnancy. And the other one is the type 2 or exogenic. When this sac grows outwards towards the bladder, and it may invade other organs also. So here the chances of rupture are very high. Myometrium is very thin or it may not be present at all. And here the primary management is by surgery. So these are the two types. Here you can see the pregnancy goes inside. Although it is implanted on scar, but it will go inside. And here it will be growing outside uterus and invading other organs. So there recently a radiological grading to better prognosticate these cases has been introduced. Here they divide these cases into 4 types, depending upon the extent of invasion over the myometrium or invasion of other organs. So in grade 1, only less than half of the myometrium is involved. In grade 2, more than 1/2 of the myometrium is invaded. In grade 3, there is a bulging out. So here is that pregnancy sac is going towards the bladder, but it is still not invading. And in grade 4, here G-sac behaves like an amorphous tumor with rich vascularity at scar and invasion of adjoining tissues. So it helps in the prognostication, basically. These are the different grades you can see. So here less than 1/2 of the myometrium is invaded. Here more than 1/2. Here it is going out but not invading organs. Here it is invading other organs also. And this is one study which said that the chances of surgery, need of blood, everything is very high in grade 4. So if we talk about the natural progression of a scar pregnancy, so very few of these pregnancies actually progress beyond first trimester. And as per evidences, it is well established that scar pregnancy is a precursor of placental accreta spectrum, which is a life-threatening situation. And if the pregnancy progresses here beyond first trimester, it would be there would be a substantial risk of catastrophic hemorrhage and life-threatening condition. It may even progress to secondary abdominal pregnancy if it perforates through that scar in early trimesters, then it could be a very difficult condition if the placenta gets implanted over important abdominal organs like liver and spleen. So now we come to the management of scar pregnancy. So there are certain general principles which we need to follow while managing these cases. The first one is the most effective cesarean scar pregnancy treatment is simultaneous application of multiple methods. That gives better results. We would see that in upcoming slides. And then in type 1 only, we can use conservative approach, not in type 2. Here, surgery is must. During conservative treatment, it is necessary to monitor the level of beta-HCG as it is an indicator of treatment efficacy. And we do it as we do it in other ectopic pregnancies. Here, the flow is also very important. The Doppler study is also very important to monitor these cases. And the options which are available there are multiple options which have been given in literature, but these main are the 5 categories. First is the expectant management. Second is only medical management when we give different drugs, either locally or systemic through systemic route, and then that is only medical method. Then DNC, curettage, also, although it is not done nowadays, but it used to be done earlier. So DNC combined with medical method to reduce the vascularization, then with or without balloon tamponade. At a time, this was the standard treatment. Now, but now we have come up with many advanced treatment options. Basically, we can do a uterine artery embolization prior to any procedure to reduce the vascular supply of that area significantly. And then later on, we can go for the hysteroscopy and evacuation. Then there is a definite surgical methods through laparoscopy or laparotomy, where we resect the whole area of scar pregnancy, and that can be combined with the prior devascularization techniques like uterine artery embolization and even internal artery ligation, internal iliac artery ligation. So these are the different options which are available to treat these cases. If we talk about the expectant management, considering the possibility of serious morbidity and even mortality, expectant management is rarely used actually. It is very rarely may be used when there is no cardiac activity and SCG titers are very low with low vascular flow. So basically it is a sign of failing pregnancy. But that also can be done with a very close monitoring. Then if patient wishes to continue pregnancy, that is another thing, that she wants this pregnancy anyhow. So if she wishes to continue pregnancy, she should be thoroughly counseled about the progression, and it should never be allowed in type 2 scar pregnancy, because we cannot play with the life of the patient. Then continuation is to be done only after informed consents and thorough counseling, even in type 1 scar pregnancy. So if we come to systemic and local methotrexate therapy, and other local treatments are also available. Systemic methotrexate therapy was used to be used very commonly earlier, but nowadays it is almost not used. Only systemic methotrexate. It may be combined with other methods. So in local, because its success rates are very low, the systemic methotrexate, as we give in ectopic pregnancy. But the local methotrexate therapy has been used. It is done under ultrasound guidance or hysteroscopic guidance in a very early pregnancy, where there is no much Doppler flow and beta SCG levels are also not that much high. But if we opt for this method, we, as I told earlier also, we need to monitor that patient thoroughly with beta SCG levels and with the Doppler study of that scar site. Then other options are like DNC. As I said, it is not used commonly now, only in poor resource setups it is used, but combined with other methods, especially Foley's catheter tamponade. Nowadays, hysteroscopic evacuation is very common, and it is useful if it has been combined with other devascularization techniques. You can either give a local methotrexate, then you do a hysteroscopic guided evacuation, or you can devascularize through UAE, then you do the hysteroscopic vascularization or even the coagulation of the implantation site. If we come to the proper surgical method, we can resect that area through laparoscopically or through laparotomy, whatever route you are comfortable with. And for type 2 cesarean scar pregnancy, this is the only method which is to be used. So here we do a wedge resection of the site, and surgical management of the implantation site enables the fertility preservation also. So it is better to, here it is better to combine it with the pre-op devascularization techniques. So then the surgery would be more appropriate. But still, consents for hysterectomy are to be taken beforehand with proper arrangement of blood components. So what are the recent advancements? In recent advancements, although HIFU has been used for fibroid for quite long now, so this has been introduced as a devascularization method for scar pregnancies. Also, people do it alone or they do it with hysteroscopic evacuation. Apart from that, there is this Beckery balloon and other double balloon catheters which are available there. They have been introduced as a better method than the Foley's tamponade. So they can also be used either alone, but very rarely they have to be combined with some other method like methotrexate or some other. But as a tamponade, they work better than a Foley's catheter. So it is a big advancement nowadays. It not for type 2 pregnancies, but for the type 1 pregnancies. So if we come to the precautions and preventions, this is the main thing which is to be followed in a case of scar pregnancy. So what would it be? If we could prevent primary cesarean sections as much as possible. That is very, very important. Taking care of all high risk factors that may cause poor wound healing that I talked about in my earlier slides, and proper interval between the pregnancies. And these are the things which we teach our juniors on day-to-day basis. This only we need to follow. All antenatal previous cesarean cases are to be advised early TBS. Till date, we used to say that the dating scan has to be done after 8-9 weeks of pregnancy because that gives a better idea about the crown rump length. But here, if you have a pregnancy with previous scar, you should do a USG as early as possible. If detected, it needs to be classified and prognostication to be done to ensure selection of right method for termination of pregnancy. So my take-home messages would be, scar pregnancy is no more an uncommon diagnosis. Anticipation and early diagnosis are the key. Pregnancy with previous scar should be handled with utmost care. Obstetricians should be well versed with all treatment modalities to manage these cases, and it should be managed only in a tertiary care center. A multidisciplinary approach is very important because nowadays with this UAE and HIFU, you need to have an interventional radiologist with you, and then there are chances of serious consequences during surgery. So you need to have a very good critical care person who would be taking care of the patient in post-op period, and then the availability of blood components. So we have to go with the multidisciplinary approach here. So thank you very much. Thanks for the patient hearing. Thank you very much, everyone. Once again, thank you.
Thank you, Dr. Veenu, for a brilliant talk. Now I request
you,
Dr. Shikha Seth to give her expert opinion.
Thank you. I congratulate Dr. Veenu for giving us such beautiful and I think a complete idea about the scar ectopic pregnancy, starting from pathophysiology, how to detect it, because nowadays with increasing number of cesarean sections, that too elective also, we are coming across a good number of ectopic pregnancy. Yes, of course, the data shows 6%. Yes, maybe sometimes we get across more number of cases, and especially the ones which have usually the type 2 and type 3 varieties, where we actually used to have an hysteroscopy and plus combined laparoscopy kind of a thing to deal with them. So that's an absolutely complete presentation, which gives us all of the idea about how we should actually identify it, what precautions we should take it. And of course, DNC is a method which should be only and only tried in a type 1 where the less than 50% of invasion is there, and it is something like the distribution which is called as endogenic kind of an scar ectopic. Yes, of course, I will absolutely agree with that, and it's something the whole team has to work on whenever there is an ectopic pregnancy, especially the type 2 and type 3 variety, where there is an extroversion of the scar is there and chances of high vascularity and invasion of the other nearby organs are there. So that's all what I can say about it. It's a nice thing. She presented very well, covering all the aspects.
Just one question I would like to ask the senior expert sitting here, and if possible, Veenu. What is the association of a long-term endometriosis in a scar pregnancy? Like in cesarean scars, we can get endometriosis, same way with the scar pregnancy. Have you come across any?
I did not come across any literature regarding this, but as I asked, I would definitely be going through more of the literature regarding this. Interesting question, ma'am. Thank you.
Okay, let me know. Yeah, thank you.
Thank you very much. Now we move on to the panel discussion. The topic is adherent placenta, real life situations. To moderate the session, we have none other than Dr. Sadhana Gupta ma'am. Madam is director at Jeevan Jyoti Hospital, co-chair, CFOG NCD committee, president.
Ritu, just
Acha, ma'am.
one question is there.
Okay,
What
ma'am.
beta acid is for Vinu and the expert as well? What level of beta HCG we can go for the conservative treatment? So Vinu, what is your comment, and our expert also?
Hello.
Dr. Binu? Hello? Dr. Binu, are you there? Ma'am, she's traveling, I suppose.
But she could present well. She could present well. At what level of beta HCG? So we can say Vijaya, you, Shashwati, Shika, and Dr.
Ma'am, as such, in normal ectopic pregnancy, also we go for a conservative method only when the beta HCG levels, even after the 48 hours, because we usually define ectopic in a scar ectopic in a similar way as we do it in the other particular areas. So we go for in 48 hours of repeat beta HCG and see whether it is more than double the value usually goes up. This is the general criteria. So normally we also take it like more than 1000 is there, and then we don't go for an conservative method. So similarly, even in this scar ectopic also, but yes, of course, less than 1000, if it comes out, it will not be able to detect on transvaginal sonography also. So that is the matter when you are only able to see the transvaginal sonography, the ectopic pregnancy, whenever the values is around 1500, or at least good sonographers also, good machines also will be able to see it just before 1400 and 1500 value. So before that, you can go for a conservative and a repeat ultrasound when you think about that. Now the value will be, if it is increasing, then the value will be around 1500, and then go for an ultrasound, check whether it is what type of actually the ectopic it is there, and then decide the thing. So if the values are below 1000, take it as a conservative method. This is what we practically are doing. Dr. Vijayalakshmi can add on something.
No, we also do the same. And I think the base thing is high degree of suspicion, especially with the history, and that alone will take us through, because quite often we ask the patient when the beta HCG is low, okay, maybe it's very, very early pregnancy, maybe your dates are wrong, come again after some time and all. But if there is a positive history of a previous cesarean scar, and also sometimes they say it can be related to a poor healing also, if we can get a good history, if there has been some pus, something and all, obviously it is all denuded, and it gives a big focus for the implantation of the placental site. So that is where the scar pregnancy ensues. So I think there has to be a high degree of suspicion in whatever we do, and don't just push away the patient saying, oh, maybe this is wrong, maybe it's a biochemical pregnancy,
yes,
maybe you are a little early, maybe you are, it doesn't take just 1 more minute or 2 minutes to just run through the history and the clinical acumen, whatever we can do, either by sonology or by clinical methods. I think the high degree of suspicion is the base for whatever we are diagnosing so early.
Yes, ma'am. Thank you.
Yeah.
Now, let's begin with the second session, that is panel discussion. And to moderate the session, we have Dr. Sadhna Gupta, ma'am. Madam is presidential candidate for the, just a minute. Yeah, she is Foxy presidential candidate election 2023. She is the most dedicated, sincere and hardworking person.
Well, that's enough.
Yes, ma'am. Second moderator is Dr. Amrita S. Jaipuria. She's consultant Obs-Gynae as gynecologist at Jaipuria, and she's president Gorakhpur Obs-Gynae Society, secretary ISOPAP Gorakhpur chapter, and secretary Gorakhpur Menopause Society.
Thank you, Ritu.
And our experts are Dr. Himali Sinha, ma'am. She is professor and HOD AIMS Patna. She is WHO fellow in high risk pregnancy, WHO fellow in epidemiology, and has many publications in her name. Another expert is Dr. Reena Srivastava ma'am. Madam is ex-professor, HOD, BRD Medical College, and she is past president, UP chapter of Obs Gynae, has organized many conferences, has numerous paper publications, and has authored many chapters. Welcome, ma'am. I request
Ritu,
Dr. Amrita ma'am to introduce.
Yeah, thank you. Okay. Sorry to say, but Reena ma'am is not well and she won't be able to join. That was the message from her daughter-in-law. And we have a galaxy of panelists, and first panelist is Dr. Sudhir Gupta. He is
Good
the
evening,
Associate Professor, Department of Obs and Gynae, a very dynamic surgeon and a wonderful teacher. His special
evening,
interests are in high-risk obstetrics and urogynecology. Next slide.
Good evening.
Dr. Tanu Verma is also a very dynamic like member of our society, Gorakhpur Obs and Gynae Society and Gorakhpur chapter of ISOPAP. And she is MD from RIIMS Ranchi. She is in railways, NER Gorakhpur. She has been she is presently the Vice President of Gorakhpur Obs and Gynae Society and Joint Secretary of ISOPAP Gorakhpur chapter. She has been the past Secretary of Gorakhpur Obs and Gynae Society. Even she has high interest in high-risk pregnancy and oncology. Dr. Amita Pandey is the Professor, Department of Obs and Gynae, King George's Medical University, Lucknow. She has many fellowships to her credit. UICC Fellowship to Philadelphia, USA. Visiting Professor, Weill Cornell Medical University, New York. She has more than 100 indexed publications in international and national journals and contributed to maternal health guidelines of Government of India, including GDM guidelines. She is the Joint Secretary LOGS, Joint Secretary IFS UP chapter, and Secretary ISOPAP Lucknow chapter. She has been the Secretary ISOPAP Lucknow chapter 2019 to 2021. Dr. Anju Parera, she is presently the President ISOPAP Bokaro chapter. She has been the past President, Vice President, Secretary and Treasurer of Bokaro Obs and Gynae Society, Director and Senior Consultant at Mother Care Hospital. She has honors and gold medals as a student and special interest in high-risk obstetrics, adolescent health and infertility. Her activities, she has organized health awareness programs at impacting 10 schools, organized free health checkups, camps at rural areas, periphery of Bokaro. Next slide, please. Dr. Namrata Bharadwaj is the consultant at Bharadwaj Nursing Home and Laparoscopic Center. She has been the ex-assistant professor, JN Medical College, Aligarh, has won several awards for paper presentations in various conferences, delivered the Kamini Rao oration for North Zone at Kolkata National Conference, chaired several sessions and conferences, various publications in Index Journal. She has been a part of Foxy Adolescent Committee, ex-treasurer, Aligarh Obs and Gynae Society, and founder secretary of Aligarh chapter of ISOPAB. Currently, she is the secretary of Aligarh Obs and Gynae Society. Next slide. Next slide. Dr. Kanchan Sharma is also very decorated. Secretary, Kanpur Obs and Gynae Society. President, IHRF Kanpur. She is ART specialist, laparoscopist, and a colposcopist. She has trainings, ART and embryo handling training from Netherlands, Rainbow, IVF Agra. Operative laparoscopic training from Mumbai, France, ultrasound and fetal medicine from AIMS Delhi. She has many awards to her credit, organized many national conferences, and she is the life member of many societies, including Foxy, IAGE, ISAR, etc. She is the Vice President, Joint Secretary, Cultural Secretary, and Treasurer. She has held all the posts at Kanpur and Obs and Gynae Society. So, over to Sadhna ma'am for
Thank
the
you.
further
Thank you for the nice
beginning
words.
of the panel. Sadhna ma'am? I'm just calling her. Something has gone on.
Madam.
Yes. So thank you. I think some internet issues. Sahiti, Shield people, please see that it is meeting somehow is being like interrupted somehow. So coming to, we will be like a little bit fast with a wonderful session. Coming, welcome all the panelists, and myself and Amrita will go with the key question. Am I audible? Am I audible? Am I
Yes,
audible?
ma'am.
Yes, ma'am.
Yes, ma'am. Yes, ma'am.
So a big gratitude for being always together. Jaswini, Dr. Sahu, Dr. Asanta Pandit, like this is a few memories which we had with the isopar. What is all is placenta accreta spectrum that we have to be very peaceful and composed while we are treating the lot of decision making. And today Vinu have said what it is normal placentation, which is going to either adhere. Actually, why we are taking this, we go straight away to the situation. What placenta accreta spectrum, the patient has delivered the baby either vaginally or you have delivered in the cesarean section. Placenta is not able to be separated. Clinical situation, what we face in the adherent placental spectrum, and that makes the thing we have to be planning ahead that happened and what could have been done. So straight away to question, yes, Sudhir and the Tanu, I think.
Yes, sir. Yes, ma'am. Hello. If during intraoperative, if you are not able to detach, your placenta is not spontaneously coming out, then we should think that it is adherent placenta. May I audible?
Yes, sir, you are.
Yes, Dr. Sudhir.
Yes, if some what happened during the intraoperative, if you see that placenta is not coming out, then you should suspect placenta may be adhere, and it may be the case of accreta or increta. In the case of percreta, you find at the time of cesarean. Sometimes we get the patients from periphery. They are opening the abdomen, and by seeing the blood vessels in front of the bladder or in front of the serosal layer of the.
We will come to it. So, Sudhir,
Yes, both in elective and emergency, we do face mild varieties of adherent placenta. So
Yes.
mild varieties we are able to manage, but if personally, if I get a patient which I haven't seen an unbooked case, I try to get a recent USG done. And in case of previous cesarean or multiparity with advanced age, we try to locate the placenta and see if this dreaded condition is there or not.
Ma'am, if
what I wanted to ask that what is the, like you are having, how much it is on the rise, or it is the status, or what is, because you are in railway institution and you are in medical college, how far it is?
Practice.
Yes, ma'am. Nowadays you are getting an increased number of the cases of placenta accreta, and suppose at the time of cesarean section, we are getting the percentage. Suppose we know that patient is a case of placenta accreta, and we take some precaution to deal such type of patients. Suppose in that condition, we always try to give the incision, and at the incision.
We will come to it. We will come to it. Actually, it is the straight question that what you are facing. So rightly you said you are taking as a, you are getting the that you are finding the emergency presentation. So that is the important thing, and definitely the incidence is going to be rise. And that is one point which I want to actually emphasize is that accreta, that all placental accreta syndrome are not the same. So at the 78% is only attachment, and increta and percreta is the lesser incidence. So this is one message which I want to give. So Amrita, you can take this question to Amita and Dr. Anju, that why really want to have that, what dreaded complications we face when we are dealing in the per-operative, pre-operative, pre-delivery, and the post-cesarean, or what we can say the post-operative. So Amita and Dr. Anju, for your comment on this.
Dr. Sadhana, you have very rightly mentioned diagnosis of placenta accreta or any form of morbidly adherent placenta is a catastrophe in the OT. Most of these patients end up with life-threatening hemorrhage. They required enormous amount of blood and FFP, PRBC, FFP and platelet transfusions, and a few of them also land up requiring ventilatory support. So these are all the complications. Moreover, at times, the bladder may be injured, and hence the help of a urologist may be needed. That is why this condition is very, very important, and we all have to learn how to manage it, because most of the times it cannot be predicted. We have seen cases where patients without any prior cesarean also have ended up with a cesarean section, an adherent placenta. And this can occur even in cases who have had a prior DNC. As simple as that.
So thank you, Dr. Amita, that actually whenever we even suspect the placenta accreta, it is not only diagnosis, even on the level of suspicion, we should be ready that we have all the resource setting, because we have all the life-threatening complications. So Amita is in a Queen Mary Medical Institution. Dr. Anju, you are at the like a small place. So what is your comment about it, that what you take away for how this life-threatening condition should be managed, and what you do in your practice?
Yeah, in this life-threatening condition, we have to prepare beforehand a team and a multidisciplinary approach. And always we have to manage these cases in a tertiary care center with all backup of ICU and all this, and multidisciplinary approach with the senior obstetrician, urosurgeon, pelvic surgeon, and this neonatologist and a good anesthetist. This should be a team approach, because even if we get this problem at the time of operation, there should be quick and fast action, and we coordinate, raise the alarm and coordinate all, and so that they quickly come and manage these cases. Also beforehand, because there is the obstetric hemorrhage and all the blood and blood component is required. So all these should be well coordinated, and it should be a teamwork.
Thank you. I think both Amita and you have actually emphasized the.
I would like to add something, Sadhana ma'am.
Yes,
Nowadays,
yes, Amita.
Because we have a very robust interventional radiology support in our institution, these days we have realized that if we, for all elective cases, we ensure that the catheter has been put in at the level of the uterine artery, and the moment the baby is delivered, the uterine artery embolization is done, and that helps us a lot as far as the removal of the placenta.
We will be coming to that. So important thing is that 50 years ago, we were losing a lot of patients. Now we can save a majority of patients. But anyway, it is something still with the 7 to 10% of the mortality. So Amrita, you go ahead with the first case. Already Dr. Veenu has taken this scar pregnancy, but how it presents in clinical situations. So Amrita, please.
Okay, ma'am. Thank you, ma'am. So we are coming to the first case situation, and this question is to Dr. Namrata Bharadwaj and Dr. Kanchan Sharma together. A 30-year-old woman with previous cesarean section 3 years ago comes with a 1 month amenorrhea and urinary pregnancy test positive. Her ultrasound shows missed abortion. Suction and evacuation is planned. As soon as suction evacuation is started, there was profuse bleeding with drop of pressure of systolic blood pressure to 70 millimeters of mercury, and pulse rate rose to 120 per minute. Resuscitation was started, blood was organized, bleeding was profuse. What next, and how do you move ahead?
Can
and
I take
what
this,
is
ma'am?
your diagnosis?
Can
What do
I
you
take this, ma'am?
suspect? Yes, yes.
Okay. We've just had a very good evening, everyone. We just had a very good talk by Dr. Binu regarding this particular scenario. The first thing that comes to our mind is a scar ectopic. Now, we have a patient who has a previous history of a cesarean section. We have a patient who's giving us a small sac in the uterus. And as soon as we start an intervention, she starts bleeding profusely. I would like to emphasize, ma'am, when we have patients with the previous cesarean and missed abortions, I would suggest to everybody, of course, madam will tell us more, that we should get a thorough TVS done so that we know that this scar, this pregnancy is not a scar ectopic. Anyway, we can, as Dr. Binu very well told us about Bakri Banul, she told us about double balloon catheterization, she told us about the other methods of stopping the bleeding. But until we know what we are dealing with, we cannot deal with it. So, of course, a cervical ectopic and vascular injuries, or maybe even a scar, the scar giving way also give rise to the same kind of problems.
I think the answer is very well given by Dr. Namrata. As was being discussed, that this may be a case of scar ectopic. Along with dealing, we have to go side by side diagnosis and maintenance of the general condition of the patient. In this particular case, we have to maintain the patient. We have to keep in our mind a case of scar ectopic and deal accordingly.
So thank you. The message from the Kanchan and Amrita is this, and what we want to give to all August audience, that anticipation of scar pregnancy is very important, because sometimes we really get call from our colleague, and I also face this situation. Patient took medical abortion, she is bleeding, and naturally it is retained product of conception, and we do this suction evacuation, and we were really not knowing that what is happening. So sepsis-induced coagulopathy is also there. Why we are discussing ARPS, we have to consider the diagnosis also. But important thing is that do very careful the transvaginal examination, keep the possibility, and you have to be very good in counseling. It is not only our setup. You have to counsel that patient might need laparotomy, patient might need the further procedure, and patient will need the blood transfusion. So important messages, because whatever the data, like what is the study shows by a wonderful paper by Dr. Indranil, that we have this scar pregnancy, or the this complication is scarnish just in emergency as a life-threatening hemorrhage. And important thing about medico-legal issue, good consent, good counseling, and always keep in this mind that it is not only the retained product of conception, and always sliding sign. And I will say that as a obstetrician, when we are doing our own ultrasound, be very careful about these observations, that where is the sac, what is this, and our radiologist friend, if you are not doing, must be aware of. So many times you will have the diagnosis of only missed abortion. And I again say one very important clinical point, that do the PV and the perispeculum examination. Sometimes you are thinking, I have 3 or 4 times that one is thinking scar pregnancy, but when you do the PS and PV, the products are already coming out. So that is the thing, that our smart clinical acumenship always to be considered. So I think we were not going to all option already. Dr. Binu had said, this is the paper which I was mentioning it, that how the life-threatening hemorrhage comes to us with the scar niche and the stimocele, and we are really aware, and we are losing the patient. So Amrita, you go ahead with this. So Sudhir, we will be very, very brief, because already we have crossed the path that we are having a busy OPD. I think every Sudhir and Tanu, you are having the, what we say, public health facility. In those patients, how you consider, how you pick up the high risk case, that this is the patient who need evaluation for the placenta accreta.
Yes.
And yes, when we
Yes,
want to be very brief and concise.
Yes, ma'am. Any patient having the history of the previous cesarean section, then we should go for the ultrasonography. And if the placenta patient is a case of placenta previa, so yes, definitely you should see for the accreta, you suspect patient may be a case of the accreta, and by the ultrasonography, a good ultrasonologist may guide you that patient is a case of accreta, percreta, or increta, and then you can. So ultrasonography is a good
ultrasound
modality.
we will come to it. We will come to it. I will say in history, आप अपने residents को जैसे you are saying. So what instruction do you do?
Yes, ma'am.
Yes,
ma'am. One thing more I would like to say: if patient having the placenta previa and there is no episode of bleeding, you should suspect accreta.
Yes, great. That is a one. This is the thing which actually a very good input, clinical input, Sudhir, that sometimes the placenta accreta doesn't bleed. And we just have like in a stationary placenta at the low line. So, Tanu, your comment about it, it is the cesarean section is a one combo, placenta previa is one combo. Any other combo can happen that if we can pick up the high risk case. Tanu, your comment about it. Besides,
Multiparity, higher maternal age, IVF pregnancy, these two are risk factors. And definitely placenta previa with a cesarean scar or anterior placenta, one has to be very cautious, order for a Doppler or repeat ultrasound.
So one thing is placenta previa, just what we want to emphasize that the history of hysteroscopic surgery, history of suction evacuation, IVF pregnancy is an independent factor for the placenta accreta. So one message to everyone who is taking their own IVF pregnancy or taking care of IVF pregnancies, that IVF pregnancies is the independent contributor to the placenta accreta spectrum. So many times we face a lot of problems about it. So always like screen well for all these things and never forget the hysteroscopic surgery where we are entering the uterine cavity and that leads to the problems of the scar defect. So this is one very, very important thing. So Namrata and Kanchan, now this is the second case situation. Amrita, you go ahead with the second case situation.
So a 31-year-old woman with previous 2 cesarean sections comes to us at 18 weeks. On ultrasound, it is anterior placenta previa, antenatal lab tests and fetal growth, everything is normal. Now, do you consider confirmation or exclusion of morbid adhesion of placenta? And
Yes.
what will be your plan for diagnosis?
Yes, this is very important that in this case, because this is a previous 2 cesarean scar, there are 2 times scar in the uterus. So we have to confirm it whether this pregnancy is accreta, increta, percreta or not, anything of them. So abnormal presentation should be ruled out in any way with a proper ultrasound and seeing the vascularity also. See, there are many signs.
Kanchan, what is when you say proper ultrasound? So they will do TIFA and they will, the ultrasoundologist will look for the baby. So what actually,
you should,
yes,
madam, you should specify to your ultrasoundologist that we have to rule out the morbidly adherent placenta, and you have to see the myometrial thickness and see the lacuna in between, see the cheese appearance, Swiss cheese appearance, which is visible in case of excessive bleeding in lacuna in of the placenta. You have to see the normal hypoechoic area between the placenta and the myometrium, which is not here in this case in these particular adherent placentae. And you have to see whether there is invasion of the bladder, which is visible in many times. So it is there or not, or there is irregular vascularization, which is visible in many cases involving whole of the uterine myometrium or reaching up to the serosa. Or many times, if there is any doubt, you can advise for the MRI. You are
so we will come to MRI. We will come to MRI. Namrata, any comment?
Yes, ma'am. Yes,
So
ma'am.
one thing is that you have to specify that we want to exclude. C, we cannot actually know confirmation. We can see C for the possibility of placenta accreta. So
Yes,
we
yes.
can say negatively that there is no sign suggestive of placenta accreta, but it is no sign suggestive of placenta accreta. So we will just go to the limitation of the both imaging technology. So Namrata, your comment on the beautiful input what Kanchan has given.
Yes, ma'am. Dr. Kanchan has actually told us in very elaborate terms. But I will again say, unless we know, we will not be able to specify. So first thing is suspicion. Be a good friend to your radiologist. Tell the radiologist, ye dekhna hai to dekhna hai. You have to see whether there is accreta or not, because our life, our patient's life, everybody's life depends on it. Number one. Number two, most patients of accreta we are able to diagnose on grayscale 2D ultrasounds, but the color Dopplers give us a better picture sometimes, because in cases in which the diagnosis in grayscale is ambiguous, we could have turbulent lateral flow, we could have gaps in myometric blood flows, which are which we can easily see by color Doppler. So color Doppler as such is not essential for diagnosis, but in ambiguous cases, we can take the help of color Doppler. And of course, the next modality is
Namrata, I think if you are really suspecting placenta accreta, then we have to do the color Doppler. So we are doing so many, not necessarily for the fetal Doppler and the growth, but it is something very, very important. And I say, if you have a reasonable good machine, you put a color Doppler on and you will see the turbulence and the blood flow coming in that, and that is the time that you have to take the best opinion. So thank you very much for Namrata and Kanchan for exercising it. So what you say that does MRI, what is the role? Kanchan said about the MRI. So I will skip this question because ultrasound has got what I want to say, that it has got its own specificity and the sensitivity. It is not 100% predictive. And you have to follow, it is not also a one-time diagnosis. Also, you have to follow the placenta accreta spectrum right from first trimester to the third trimester. So what I want to emphasize with the study is that it is not 100% sensitivity and specificity, around 88 to 95%. And as a clinician, we have to be sometime ready for an unexpected thing. So this is important that when the expertise is sometime and the workload is too much, you have to send these patients to the best person in your city, that what is there, the sign suggestive of placenta accreta. And this is very important, that absence, if you have the absence of the ultrasound sign of the placenta perfida, even then if the clinical spectrum is like that previous cesarean placenta previa, when you are doing cesarean section, be ready that you have the backup as in the case of placenta perfida. If it is not there, it's okay. So with the Why Mothers Died, what is a confidential inquiry of maternal death by the Dr. Pelly, and he illustrates 2 or 3 patients because the team was ready for the backup, so negative placenta perfida, but because they were ready, they could save the patient. So this is very, very clinical message which we want to give to all opinions. So with this, it is 18 weeks, it is good ultrasound. They say that it is a placenta accreta, not perfida. So Tanu, how frequent ultrasound? Now this is at 18 weeks. What Amrita says, it is 18 weeks. So what next? अब आप इसको कैसे फॉलो करेंगे कि उसको अभी से तो हम नहीं डराएंगे, but you have to carry with this pregnancy. So Tanu and Sudhir, how to?
Yes, ma'am. We do the patient on the we follow the patient same like the or the patient. Suppose patient is a case of placenta previa, then we ask patient to take some so do not do heavy work, and just we say that your placenta is, but because after 16 weeks if placenta is low lying, then we ask patient to come frequently and ask patient if there is any bleeding comes through, and do the ultrasonography in after at next in the next second trimester. And because there is quite obvious chance in case 40% chance that placenta may migrate with the growth of the fetus, so it is quite obvious if placenta is not covering the os. And so we are not asking patient that you should be very, and we are not saying patient that there is a chance of accreta, but we are saying yes, they should take some precaution. And we do the regular, we ask patient to follow regularly at 28 weeks, up to the 28 weeks monthly, and then fortnightly, and after 32 weeks, we ask patient to come at as weekly, or after 34 ask patient to come weekly and do the
Thank you,
ultrasonography.
Sudhir. Yes, so one message that we should be in a protocol.
The follow-up is the
must be.
same.
Yes.
And we
Yes,
need
yes.
to build we need
So
to
what-
see whether the hemoglobin status,
Yes,
arrangement of blood is there, and keep on counseling and elective cesarean hysterectomy at 35.
So we will come
With
to that.
backup
Actually,
team.
one message which we want to give, that you have said that a suspicion of placenta accreta or placenta previa with the clinical setup, then you have to follow 18 to 20 week, 28 to 30 week, and 30 to 34, because sometimes the things get changed, like the placenta become upper uterine segment. If it is extending to bladder or other organ, then our team, like management, has to be very, very aggressive. So set the protocol. After every question, we want to have a set protocol in your clinical practice as well as the institution. And it is important, again emphasize that take the consultation of the best ultrasonologist for this situation. Never take responsibility on your own, because it has a potential criticality and the potential medico-legal issue. So Kanchan was talking about MRI. So Amita, your comment about it, how useful is MRI for the diagnosis of the placenta accreta spectrum? Amita, your comment.
Yes, Sadha ma'am, definitely. As per literature, MRI is the gold standard for assessment of placenta accreta or morbidly adherent placenta. But believe me, even ultrasound, good ultrasound with color Doppler can give a fair idea. You can see the Knitterbox, absence of Knitterbox layer very carefully. You can see traversing vessels. You can get to see placental lakes, and these itself are very, very diagnostic. You may not have to really go ahead with MRI just for the diagnosis.
Just before we go to, actually, Amita, you said rightly that ultrasound is suffice. I will say one step ahead, that no professional body and overall wide experience expertise says that MRI is add much to it. So MRI is considered only in select situation. It is actually not a gold standard. It is between it when the sonography results is inconclusive, that you are having two people like observation reports and you don't know what to do, or the posterior placenta previa, and when you are not sure that what is the extent of invasion, especially lateral. So what I want to emphasize to all audience, that all professional body, and it is a latest, what is the International Society of Placenta Accreta Spectrum thing, that the MRI, the color Doppler and a well-done ultrasound is actually the most important tool, and MRI only adds in those situations when actually you have a inconclusive, or this is the posterior placenta previa. This is one very, very important study, that based on MRI, they changed the management course, and in about 1/3 of the cases, their MRI observation was wrong. So one message, that MRI in select cases, and MRI, like what is there, like uniformity of description, because it is also not able to address so well by the obstetrician across the country. So one important message, that the 3D, what Amita also emphasized, that the 3D and color Doppler is the best tool, and MRI when it is inconclusive. So Anju, your comment about the use of MRI, because today what we are seeing, a lot of MRI is being done for gynae purpose and the obstetrical purpose, but actually how far it adds to our clinical decision, we know. Anju, your comment about MRI on
you have rightly said, madam, that ultrasound and color Doppler 3D ultrasound is sufficient to diagnose, but only in those cases which you have nicely enumerated, that equivocal USG finding of abnormal placentation in case of posterior placenta previa. And one thing I add, in very obese, because nowadays obesity, obese patients are more. So in obese patient, MRI is a little bit more helpful. And in the lateral invasion, which is MRI is more useful. Otherwise, ultrasound, good ultrasound report with the color Doppler and 3D, it is sufficient.
So quick comment from Kanchan about any biomarker if you are using. Any biomarker you are using for diagnosis or you are not using?
Any biomarker, madam, by the clinical examination, biomarker, we are...
you are not using, I think.
Yeah,
there
yeah.
are few biomarkers actually.
What you are doing, yes, you are right also, because we don't have any strong biomarker. Yes, Namrata.
Ma'am, what I would like to say is rather than going for biomarkers, as you rightly said, it is much better we going for a good TVS, because biomarkers
Good
are very
TVS and the ultrasound color Doppler we are doing at our own clinic.
Ultrasound is, I think, the gold standard.
What we want to communicate, what we want to communicate actually, what we want to communicate that we don't have any very strong biomarker for placenta accreta spectrum. So what we want to give message that actually we don't have any strong biomarker. So Amita, your comment about, because you are in a research setting, Amita, your comment about the biomarker, are you using for the research setting or something? Because we are looking for a biomarker, but we don't have till now. So, Amita,
Madam, we are really not using these biomarkers in our day-to-day clinical practice.
I hope that you can have few research topics now, because actually we are looking for it, but we are not able to find anyone. So, like you, it is a placenta accreta spectrum. So, Sudhir and Tanu, how do you? Tanu has already said about the anemia, very, very important. So, coming to the next question, that when to deliver these babies with the placenta accreta. So, I think anemia is very, very important. Tanu have already said if there is a bleeding, then give anti-D immunoglobulin. So how you go ahead with the all preparation? So Tanu, your takeaway for it. Antenatal care. Tanu, are you there? Sudhir?
Yes, ma'am. Yes, ma'am.
Yes,
ma'am. The best time. Yes, ma'am. The best time for the termination is from 35 to 37 week. We should deliver the baby. If patient is a case of placenta previa or placenta accreta, it should be terminated before 37 week of the pregnancy, and sometimes before 37 or 34, 35 weeks. So we should give the steroid beforehand, because yes, quite obvious, if patient may land up in the antepartum hemorrhage. So we have to prepare for the, we go for the blood group, and we arrange the blood pre-hand, and at the same time her hemoglobin should be optimized before during the pregnancy. We should check for the anemia, and we optimize the patient. And when we plan for the surgery, beforehand we have at least 3 units of the blood.
We will come to that. So one point is, it is around 34 to 35. Actually, when we reach up to 37, then we have to be ready for any emergency onset of labor pain, which we actually don't want to have the surgery for the emergency. So around 35 to 36 week is the right time. And if it is a prom or any vaginal bleeding, then around 34 week also. So actually, these are the life-saving decisions. If you are deferring up to 37 week, your institution must be ready to deal these patients in the emergency hours. So this is very important. Always steroid, because anytime you have to go for the cesarean section. So steroid trialing around 31 to 32 week is a fair enough approach about it. And the important thing which is that when we have diagnosed it is a possible or the probable or the confirmed case of placenta accreta, counseling of family. We daily these are patients who are not financially well prepared, who are not ready for anything. So during antenatal care, we have to tell them कि आपका delivery यहाँ पे होगा, आपको blood की जरूरत पड़ सकती है, आपको donor की जरूरत पड़ सकती है, आपको hysterectomy की जरूरत पड़ सकती है, because the family, only our readiness also doesn't matter, the family readiness is also important. So that is a part of antenatal care. Like improving anemia, this is also part of antenatal care. And one message that around 35 to 36 is the right time for the diagnosis. So Now, this is the question which is actually to Amita and Anju, that you are doing a cesarean section in an emergency patient, and this is, I think this is, this we have done. I think we will go to the last. So this is, you have done you are doing emergency cesarean section, and you are suddenly encountering the situation. Oh, what is it, and where to give incision, and you are resident. It is why I think we can go for Amita for this question. That what you do when you find an unexpected placenta previa, like your third year resident is doing cesarean section. So how to anticipate? आपको क्या देखें हमें लगे कि stop it and do next. So Amita, you.
The moment the resident you mean to say that when the surgery has already started?
Yes. The patient you are doing cesarean for APH and it found to be such. Yes.
Yes. So the moment the abdomen is opened, first thing, in all cases of APH or in all cases of placenta previa, suspected morbidly adherent placenta, we usually tell our residents to open with a midline vertical incision or a paramedian incision. Number two, the moment she opens the abdomen, and she has to look for vascularity at the lower end of the uterus near the bladder. Number three, if the pushing down the bladder is difficult, or if the patient starts bleeding, the first thing is, it is better she should stop pushing down the bladder. She should not aim for that. Give an incision in the upper uterine segment, take out the baby. The moment the baby is taken out, the cord is clamped and cut. Immediately a tourniquet should be tied at the lower end of the uterus. One person has to lift up the uterus and the other person has to tie a tourniquet. If you don't have a tourniquet, you can just use a bandage, a sterile bandage, doubled up. Just tie it all around so that the bleeding is temporarily stopped, and without wasting time, without trying to pull or tug at a morbidly adherent placenta, one must start and proceed for hysterectomy.
Great input, Amita. Wonderful input, and that tourniquet, that is the tip and trick for all, that if you are finding the unexpectedly placenta accreta or a like situation, that is a very, very doable thing. Kanchan, Amita ji is in like a institution, so there is also, Kanchan, you are in a private sector, so you find you are doing cesarean section and suddenly you find this thing. So what you do as a single person?
Actually, madam, if this patient is referred to my center, first of all, I before opening the patient, I should suspect the placenta accreta. And in my personal institute, I will do the color Doppler and suspect this, counsel the patient very well that this can happen, and I have to do the cesarean hysterectomy.
Yeah. Can I take this, ma'am? Because I have faced this.
Yes,
okay,
yes,
ma'am, I think in a small setup, Amita ma'am has given us wonderful inputs as far as her institute is concerned. In a private setup, I think it is better to know what not to do rather than what to do first. First thing, as soon as you open and you suspect a placenta accreta, just stop. Gather your resources, gather a senior team. If the patient is not bleeding and you don't have the resources, you don't have a backup, you don't have a post-op backup, just close and transfer the patient. Number one. It is
before
better
opening, you should suspect.
नहीं मैम suspicion मैम कह रही है ना जब open करने के बाद
होना चाहिए before opening, that I said.
दूसरी चीज मैम, it is better to look like a fool rather than to lose a patient. You know, just transfer the patient. Number two, ma'am, if in case the placenta has already started separating. You know, sometimes it happens as soon as you touch the uterus, the process of labor starts. If it has already started hemorrhaging, then as Dr. Amita rightly said, tie a tourniquet, you try any kind of, hemostatic methods and immediately call for help. Your neighbor, your senior, your whatever, just call for help. I think that is most important. Don't touch the placenta. Take the baby out away from the placenta. Don't try and tug at the placenta. Just try and remove the uterus and lock along with the placenta. And of course, as
I was saying, first you diagnose it, then try to touch or not to touch, that you have to decide.
Actually, we are going, it is a should keep, like there is no limit to should. I think as a professional body, and we also see everyone as a potential leader in the professional body, we have to take care of any setting. We have to say,
Yeah.
Mother, so what is a ultrasound 80 to 90%? It is not 100%. MRI, it is around 95%. So we are going to encounter such situations.
Ma'am,
So
counsel
yes,
and say that you have to refer to the tertiary center or not.
Ma'am, one thing I would like to say, the
Yes.
very easy way to manage the placenta accreta, adherent placenta, anything. If patient is not bleeding, suppose you open the abdomen and you are seeing the blood vessels are running above the serosal layer or the bladder layer, you just go do the classical cesarean section, give the incision in the fundus region, at the fundus, top of the fundus, take out the baby and cut the climb the cord and leave the placenta as it is. There is no bleeding. We have did such type of cases in the medical college, 10 to 12 cases, and every patient was very fine. After 2-3 months, we do the hysterectomy to the dead patient. And in some of the patient, not even single blood was given. And they behave like this.
Yes, sir. Thank you very much. So I think with a great discussion,
You leave the placenta at the site.
Sudhir and Namrata and Kanchan, I think this is the way. Why? Because we have the different experience, and that is the value of such panel actually, because we want to talk what is happening. So everybody is right. So first of all, we can have any time, and so we know, and like unexpected placenta previa or the accreta. So first of all, good identification. This patient can be having placenta previa. Secondly, don't go straight away for cesarean section. Either you organize your team or you refer. जब कोविड था तो इन माय केस सुधीर मैंने रोमा ने उस पेशेंट को किया था जब कोविड था लॉकडाउन था नो स्टाफ वाज कमिंग आफ्टर ओपनिंग आई blocked. I didn't even try to deliver the baby. We closed the abdomen and organized because we have actually nothing to do because blood Vinita, assistant Vinita, nobody was there. So there is no shame in it. You can close the abdomen, call to your HOD, what is called to your tertiary care aims, whatever it is, organize referral, make a good referral note and go ahead. Or you call all your people, like a 3 or 4 unit of blood, your experienced urologist, general surgeon, and then go ahead because you don't want to have the nightmarish situation. And what Sudhir is talking about, the delayed hysterectomy, or sometimes it may resolve also. So placenta accreta is not always a perfita. It is a accreta, it is a focal, it can be in various spectrum, and few patients we can do it. So one question, I think it is already to Tanu, that suddenly, like you say that the patient didn't bleed, very lucky, but suddenly as soon as the baby is delivered, and the one message that never give oxytocin or carbitocin as a active management of third stage of labor in any suspected placenta accreta, because if you have uterus start contracting, then there will be the very important like a hemorrhage. So always allow the time that if it is spontaneously separating, it is fine, but if it is not adherent, then it's okay. So when the patient, now this question that what you talk about, this you were not lucky, this patient was not lucky, you are not lucky, and suddenly as soon as you deliver the baby, torrential bleeding. So what you do when you are not in hospital, you are in your Greenland hospital. So what you do?
Ma'am, what the madam told us, first use the tourniquet. That is a very easy and effective way to control the bleeding. You just encircle the lower uterine segment by any mean. Then the bleeding will stop and you go for the cesarean hysterectomy.
So you have to do.
We can go for bilateral uterine artery ligation.
Yes, at that time, no, ma'am. Now, one thing I like to say, ma'am, we have a lot of patients referred from the periphery. At that time, doing the uterine artery ligation is really difficult because at that side there is a lot of blood vessels. So yes, if you can go for the internal iliac ligation. For the time being, it will help up to some extent. But even after ligating the internal iliac artery, you have the torrential bleeding from the lower uterine segment or the bladder base. So it is not helped you. So you have to do the cesarean hysterectomy. Suppose it is not possible to complete your complete hysterectomy, you do the subtotal hysterectomy and do the box suture at the uterine, at the bladder and some part of the lower segment. For the time being, you will there will be the hemostasis. Sometimes bladder, maybe you have the hematuria in the blood, you don't bother, and just maintain the hemostasis. After some time, I did there we cut the bladder during that procedure, but after 2-3 months we send patient the urologist. Now patient is fine, they will repair the bladder, but yes, we save the patient.
Thank you, Sudhir, for wonderful input. Actually,
you can
this
call
is
the
very
urologist on the
important.
site also, no? They can repair.
At that time, in the emergencies, it is quite obvious you will not get the urologist around
So
the
we are
clock.
really talking about not a realistic picture. Thank you, Sudhir, for wonderful input, because that point I wanted to deliver, that internal iliac artery ligation as well as the internal, like interventional radiologist. Placenta accreta, a lot of collaterals are there. A lot of collaterals are there, and that is not that effective what we have in elective like surgery, internal iliac and the interventional radiology, because a lot of collateral and the angiogenesis is there. And what is it? Is a tourniquet and all the quick hysterectomy and all your team. So thank you, Sudhir, for it, and you're taking that you do that hysterectomy and do the box suture. So this is very, very important. Any experience of the like the every obstetrician is well versed that is a balloon tympanoid or the balloon catheter and the like aortic clamp. Anybody, Sudhir, you are using, Amita, you are using in your institution, our own Dr. VP Pally's aortic clamp. So any idea about the additional measure for the hemostasis? So it is all about Sudhir, your balloon tympanoid can be effective, especially
Yes, ma'am. Yes, ma'am. We are using the balloon tamponade. Suppose sometimes even after there is a adherent placenta, after doing the cesarean section, we got that there is a bleeding trickling from the uterus. We are using the balloon catheter. That is helpful.
So this is the additional measure should be available, and it is all about creating bladder flap and this thing. So Amita, are you there, Amita? Kyunki main dekh nahi pa rahi hu. Haan, Amita, so you are in the prime institution. So this is the gap in the system, what we say, that in our country we are really having center of excellence, and what you say that how we should create center of excellence in every city or every region. So your comment about it, Anju and Dr. Amita, because Anju is coming from a like a different setting, and Amita, so what you say that how we should create it? Yes, certainly. We in this era where primary cesarean sections are increasing, we all are bound to get more and more cases of morbidly adherent placenta and the entire spectrum. So we do need centers of excellence. And by these center of excellence, I mean that everything under one roof. There should be a blood storage facility there where immediate blood is available. There should be interventional radiology over there. There should be a ventilatory unit in the same place, in the same building, so that patients do not need to be transferred. There should be an availability of good anesthesiologist and urologist over there, along with surgical backup, good surgical backup at these center of excellence, and these must be made these days, because without these, we are definitely going to lose a lot many patients to this morbidly adherent placenta spectrum. So thank you. This is the area where we have to work together, that we create center of excellence, and there should be like everybody should be confident that if this patient is there, we are going to refer to them, and they must also have a good like experience also, and they should be available 24/7 on a sequence. What is SOP that हमको एक दिन पहले क्या करना? We have to review what on the day of surgery, what anesthesia, what is the exposure, what will be the position, that is a Lloyd. So they are really perfect in their thing. They are adequately experienced and the well team. So this is the area where like we have to work together for all the decisions. So it is all that what like obstetrical team will be do, what is the gynae team will be doing. It is not just like a tackling with one situation, but we have to be ready with a very, very like a coordination fashion. So Namrata and Kanchan, this is again, I think Anju we are missing. So Anju, after you have done a wonderful cesarean hysterectomy, and after that, how do you like go for the post-operative care? So Namrata and Kanchan,
yes, ma'am. Okay, ma'am. She may have lost a lot of blood, so we would require the packed RBCs and platelets of FFPs. she needs to be shifted to ICU even if she has not lost blood, because these are patients who may land up with the ARF, they may land up with ARDS, they may land up with some kind of injuries, like bladder or intestinal injuries, which may have been overlooked during the surgical procedure. Now, they are the patients because of massive obstetric hemorrhage, they may land up into DIC. So, a proper ICU with a proper anesthetic, critical care person needs to look after her at least for the first 24 to 48 hours. Still she becomes stabilized.
So this is again a very,
Right.
very important
Yeah.
area, because
Very important
yes.
is the post-operative care, madam, here, because even in the post-operative care, these patients may go into the renal failure. They may have to be under strict supervision for their, sometimes they may need even the blood transfusion during this time. So proper ICU care is still needed, and the baseline assessment of the coagulation profile should be there even in the post-operative time in these patients.
So nothing, story is not over. You have to ready with the many life-threatening complications like ARDS, coagulopathy, and a blood profile, and always redose antibiotic. It is again just for the sepsis. Add to everything, sepsis add to everything. So it is a prolonged surgery, then reload, and always keep the patient warm. This is very, very important, because under massive good transfusion protocol. So I think Sudhir and Tanu, I think at our place we don't have the interventional radiology. Amita was saying that they have. So Pally aortic clamp, I think he has a wonderful series of the patient, because they are tackling interventional radiology. You have a very good experience, Amita. So your comment, Sudhir, हम लोग के यहाँ है क्या एम्स में डॉक्टर शिखा अगर हमारे पास है, interventional radiology is available at our city?
No, ma'am. No,
it is
interventional radiologist available. So what we do our own. We do the tourniquet, and because yes, at the place of we are not using the clamp, but yes, we are using the tourniquet, or using the uterine artery, or in fact internal iliac ligation, but we have no international
it is not
intervention
available.
in radiology.
So one thing is there, that it is an issue of availability is there, but how far efficacy? Because Amita, you said it is very good adjuvant. Yes, it must be. But
yes, it is very good. Here I would like to add, it is a very good method to decrease blood loss, but it comes with a rider. At times, when the balloon catheter is being placed, at times it may trigger uterine contraction and the patient may start bleeding. So one must be prepared to just jump in and do a surgery. The problem at our place is our patients have to go to the Department of Interventional Radiology for the catheter placement, and then they have to be transferred back to our department. That is why I think, as you said rightly, we need to have a center of excellence with everything under one roof.
Actually, Amita, what study says, all over professional body are not sure, and they actually don't recommend that it is something essential. Of course, it adds to reduction in bleeding, it adds to reduction in criticality.
Because we have seen it triggers uterine contraction and placental separation and bleeding.
And sometimes what learning curve we have with our resident, with senior, the radiologists also have the learning curve. So a lot of issues with the thrombosis and the vessel injury. So every professional field has to have his own learning curve. So BP Pally, so Sudhir, I will say Namrata, everybody that you purchase, because you are dealing with the referred case in your medical college. So you have this aortic clamp, because it is something very, very important, life-saving. Do you do ureteric stenting to all, or in certain cases? So they and Amita, I think both of you can take this question. Ureteric stenting.
Yes, ma'am. During at the time, no, ma'am. Not in this emergency cases, but yes, when we plan for the Bardheim cystectomy, we ask urologist to put a ureteric catheter.
No, not for the Zamir to placenta acrita only.
No.
So it is
never.
not indicated. So
It is
it is
never
right.
indicated. In fact, putting in a ureteric catheter may again trigger a uterine contraction and placental separation.
Thank
So
you
no
for
intervention.
So thank you very much for clear message.
Include a
And,
neurosurgeon with the team.
Yes, Anju, we are missing one or two questions because they have been answered. So Anju, it is for you for conservative surgery. So this says about leaving placenta and a good thing about it. And a conservative surgery, that is end block resection and the repair. So your last comment about conservative surgery, because obstetrical hysterectomy is the safest thing to save life. Conservative, how do you select the case? Yes, in this situation we can do it. Anju, your comment, Amita, your comment about the.
I would never recommend a conservative surgery. Even if it is being done, it should be a very temporary procedure so that the patient can be shifted to a higher and a better center where definitive surgery can be done. We have tried it a couple of times in cases with very early pregnancy, 24, 25 weeks pregnancy with an adherent placenta. Hysterectomy was done. The patient was not bleeding. We tried to stitch it up, give her methotrexate, but it failed terribly. The patient ended up with life-threatening hemorrhage, and one patient had a severe sepsis, life-threatening sepsis also. So I personally, and there are no studies which recommend these procedures. So I would definitely say that in this era of medical legal liability, we need to play very safe. And the safest would be going ahead with a hysterectomy.
Thank you, Amita. For Anju, your comment about conservative, that is end block resection.
Only if there is limitation of the resources, then conservative surgery can be done, and time is bought to refer the patient to the higher center, or methotrexate is given, and after this ultimately land up in hysterectomy. And if there is focal placenta acrita, in that case, role of conservative surgery, that you take out the placenta and leave that portion which is adherent, and so that bleeding will less, and the balloon therapy is given to prevent the hysterectomy. So those in partial and in those conditions, conservative approach can be done.
What we can say, actually, conservative approach need more actually disciplinary care, because we have to have a more careful, because hysterectomy is done when the patient is better. So it is just a focal placenta acrita. It is where it has been found that it can have a place. Methotrexate, Anju, you have said, Amita said, Amita experience was not good, and it is in accordance with all the research.
Actually, I have no experience
not to be given. I will give very, very clear message to all audience who are with us till now, that no methotrexate is to be given. Even if you are going for spontaneous resorption, it's fine, because methotrexate is adding to adversity and criticality and mortality. So this is one important message. Triple P, a few Western world people are saying that is pre-operative location, devascularization, then the end block section of the placenta. But important thing is that there is a lot of inconsistency, and what the International Society of Placenta Acrita Spectrum is worried, that actually should be the histopathological diagnosis. We have to see retrospectively whether it was it, or we have the inconsistency in reporting. So conservative measures may be a very, very mild degree of the placenta acrita where they fail, and we cannot give any clear messages that it should be followed by clinicians. So what Amita's message was very clear, that the obstetrical hysterectomy is the safest thing. It is the latest view of all the experts, that is ISAIP, and we will say many panelists can be the member of this ISAIP, because you have a lot of experience and you can contribute, and it is for the very, very in select situation. So finally, it is always a life-threatening condition, and we must have the center of excellence, and we must be aware in our OPD setting, in our ultrasound setting, that we don't miss these cases. So thank you for the very, very active discussion. Set the protocol. That is the thing. We have to be very organized in mind. And with this, I seek everybody's support for my Foxy presidential candidature. We have a lot of bridging gaps in our healthcare. We have a lot of talent among us, and that is the way that we have to be worked in a very, very coordinated manner.
Thank you, Madam.
Thank you very much. Thank you very much. And now
Thank you.
Thank you.
Thank
Thank you.
you
So nice.
Madam, all the best.
Thank you,
Thank you,
ma'am.
madam, for involving all of
Amrita,
us,
you are-
and best wishes, our best wishes to you.
Sadhna, just two things. The
Yes,
panel was
Vidya.
very clear, very confirmatory messages. Just want to add two things. One is when you leave a little bit of placenta there, I did have a case. Of course, we are aware that hysterectomy is the best, but sometimes once I have done this, what we call as a resection reconstruction, and you just remove, just like you do a myoma, submucous myoma, the way you remove while you do cesarean, if you are doing, then the same way, if a small bit is just attached, you can do that, and it does help. Of course, you have to be guarded about hemorrhage, you have to be guarded about sepsis. That is one very important thing. As you rightly said, methotrexate has no role and is contraindicated. And the third thing is, of course, if you leave a small bit, it easily resolves as well. So just for, you don't try to keep plucking out a little bit if you leave. I had experiences where it was even left behind and it spontaneously resolved in a while. Of course, these are all 1 in 100 cases maybe, but then it does happen. So thank you very much. That was a very, very clear panel.
Dr. Himali is with us, and we like to have your expert comment in the end. And Dr. Himali is working in AIMS Patna, so she is having like a lot of experience. So Dr. Himali, your comment.
Yeah, thank you, Dr. Sadhna. I'd just like to add to all the discussion that a very meticulous history is important in every case so that we look for the risk factors. And in case we don't have facility in our setup, we can always refer the patient timely. I am very lucky. I'm working in a center. We have intervention radiology. They are helping us 24/7 whenever we call them. And we have, I have never been faced in a situation getting stuck, like this, because we have getting a lot of cases, but meticulous history where we know which are the high risk cases, screen them, and then of course take help. But I'm talking about centers which do not have the intervention radiology facility. Then even in those cases, this message should go out that a good history is very important, where we look for the risk factors, and then we can screen such patients and refer them timely, instead of being stuck with the abdomen open and then lots of things. And another thing I'd just like to emphasize, which has been brought up, that counseling of the patient and the family is very important at every stage. Taking the patient into confidence, because they have wrong perception, and that is what causes a lot of confusion a lot of times. And yes, I like the idea about a specialist center, a center of excellence. That's a good idea. I think we can all work towards it. And maybe if each region has one center of excellence, that itself would be a very good thing. Thank you. That was a very good discussion, very lively.
Thank you, Dr. Himali, for a wonderful. And thank you, Amrita. I was looking for you. Then I thought you were in the track. So I really say, so I go ahead. I hope that it is okay.
No,
So
ma'am,
Dr.
I was all the time here.
I think anterior placenta everybody remembers, but posterior placenta maybe forget that there could be previa.
And the patient without history of cesarean section. These are also cases we miss. Actually, we don't think about the fundal adherent placenta, which was a norm, like in our residency and first 10 years of practice, fundal adherent placenta, because of the grand multiparity and something. Dr. Gangadhar Sahu, we are thank you, like all expert panel and all sharing of experience. And Dr. Himali and everybody, like we have to work for creating that center of excellence in every region. So that is a need of the time. If Dr. Gangadhar Sahu, your comment about it.
My comment is very specific, and it is a critical analysis rather. So how many minutes I can take, madam?
As much as you want, sir.
Amrita will tell.
Amrita, how many minutes at your disposal?
As much as you want, sir.
No, I will take few minutes only. From my experience, I am telling that when we are discussing among each other with a team, with answers are in front of us, then the solution of the problem is very easy. I think you catch my point. When we are discussing with the answer written in front of us, That means you see in this situation, what will you do? You are writing 1, 2, 3, 4, it is very easy. But when you are in the labor room alone or in the OT, how do you face it? So I am telling my experience 40 years back in 1980, 82, in between that. I was posted in a subdivisional headquarter hospital, a remote most area of Odisha. Their facilities, what to think of blood transfusion, even blood grouping and RH typing was hardly could be done there. That's number one. Oxygen supply, in 99% of days, it is not available. So 2 cases of placenta accreta I had encountered there. First one from a very poor person from a remote most village came with history of labor pain and she delivered. Vaginal delivery, nothing. But when we tried to, for the placental removal, so we failed. I myself and one of my friends were the both specialists there, one looking after gynecology and another is for the postpartum center for his family planning part. So we decided that nothing could be done. Blood is not available. So there is, luckily she was not having bleeding. So what we did, as for the standard teaching at that time, we tied the cord from the as close as to the cervix and we gave methotrexate tablets. At that time, tablets were available and methotrexate was being recommended to use at that period. So then we observed her for 1 week, then we discharged. Then after few weeks, that fellow came with in a bag carrying a place of mass showing to us, sir, this she expelled. So that was luckily that she survived. That is one. Second case. Second, gradually, as we were doing surgery, gradually we became famous gynecologists there. So people from distant places, they came. And one case of previous cesarean section came and we waited for repeat cesarean section, elective cesarean section. And for if I speak the truth, at that time, the concept of there may be an adherent placenta that was not there in your mind, number one. Number two, if at all it is there, there is no gadget to diagnose. So there is nowhere there is ultrasound, some even plain ultrasound, nothing. So we could diagnose it. Anyway, so we fortunately on that day, we are hiring anesthesiologist from Medical College Burla. We are keeping routine cases in that day on that day. So after finishing the routine cases in the afternoon, we kept the previous cesarean case. So we did it. There was no oxygen supply. There is no blood transfusion facility. So again, it was late afternoon and evening, and electric line got off. So you are doing a cesarean section only with your assistant, one gynecologist, the sister. Then after delivery, we saw that placenta is adherent. We are not prepared for hysterectomy. So in between that, we asked the sister to prepare for hysterectomy. So she prepared, it took half an hour. So during that period, we tried to give oxytocin and ergometrin and try to pull and push the placenta. But why it will come out? So after half an hour, we started the hysterectomy and it was completed. So few things came to our mind from that we experienced. What will the outcome? I will tell later. That while you are going for hysterectomy following cesarean section, are we taking care of the cut edges of the uterus or not? During that period, so she must be bleeding. Therefore, that point also should be taken into consideration, whatever small amount or big amount it may be, because it's highly vascular. So cut edges of the uterus must be bleeding, and that bleeding should be taken care of. That is one point we learned. Second point.
Recommendation also, I think, like what we do, it is a fundal incision and quick closure of hysterectomy and proceed to hysterectomy. So this is the quick closure of the classical cesarean section. It is never to be left like that. Yes.
So then what we did after completion of the uterus, the patient to recover, there is no facility for general anesthesia also. So by good luck, we could finish it. At that time, we were doing cesareans under local anesthesia or open ether. So with open ether, whatever it may be, that was supplemented. Recovery was good. Patient was shifted to the ward, and the ward is general ward. No nothing, no facility. So only one sister is to look after. And next day morning, when I came to OPD round, first I went to that bed to see what is the condition. The bed was empty, and a note was the sister handed over to me, that is written by the attendant of the patient. That thank you, Dr. Sahu, you had tried hard because of in the difficult situation. I was blessed with a son, but I am leaving my dead wife. So thank you very much for your help. So that was the letter given to me, that what is the cause of death, I could not know. So that is the second bad experience. And third point, practical point, we miss sometimes in cases of RH negative patients, if such things do happen. So again, blood transfusion is a problem. So in such cases, actually, if one case should be referred to the Center of Excellence, I will say that it is RH negative patients, they should be referred to those cases earlier. And if you want to make it a principle to refer to Centers of Excellence, then out of 140 crores of people, so how many patients will refer to the tertiary centers or higher excellence centers? Therefore, you should have expert hands. So what should you do for that? Train your postgraduate students. Not only they are counting their career with the number of cesareans they are doing, so rather they should be trained with cesarean hysterectomy more than this. That's number one. Number two, how many of us are teaching our students or interns or our juniors about internal iliac artery ligation? How many of us are expert in that? That we must introspect and we can find out that problem, and that should be solved. So in these complexities, gradually, so what is being transferring our technology from past to present to future? Earlier, we are doing for, say, different maneuvers we are dealt with for breech delivery, for everything. Now we are doing cesarean sections. So we are doing cesarean sections means we should be prepared for the aftermath. What will happen in the next subsequent pregnancies? So those things keeping in mind, our next generation should be trained in that line. Simply referring means I can say you are escaping from the situation. Let us face it, face the challenge bravely and solve it. So Almighty is there. He is there.
Sir, thank you. Actually, when we listen to experience like this, we think that we are in a very good era. And now it is like unimaginable actually that the light is not on oxygen and we could not, and now the patients are also not like that. So the way ahead is that we should be very fortunate that we are working in a time when our government and bureaucracy and ourselves are there for like taking no chance. It is a total safety thing. And what, sir, it is actually actually we need so many people, no single person. Today's is a medical legal violence and it is for safety. Actually, it is again we leave everything even for the safety. The way forward is thus, and like one or two hospital where we can send the patient, because a lot of effort is needed and no chance for the life or the health compromise. So Vijaya, you are with us, and I think the way ahead is to at least every resident should know that you are an unexpected thing and how to deal with it. But even the well-planned care is the thing what we need, what we like to go for in the future. So Vijaya, your comment about this, and it is something very scary to listen experiences of Dr. Sahu. That Vijaya, your comment about it.
I think it is definitely very, very important that all of us improve. And I fully agree with Dr. Sahu that, yes, today we are able to refer and we keep referring, but it is also important that we develop skills. And I think in a little peripheral places, they are able to manage. It's not that they cannot do anything. The only scary thing is always in obstetrics is the hemorrhage. And I think every case, whether you do a cesarean or a normal delivery, is bound to have hemorrhages. You have to be prepared. The only thing is it's just a matter of massive hemorrhage or a little less hemorrhage. But I think no case, in fact, in our institution, even while you prepare for an emergency cesarean, of course, our institution is equipped for it. But even if when we shift as an emergency cesarean, the first thing anesthetist will ask is there any blood at all? Even whether you arrange verbally, at least there has to be some preparedness for blood, because any cesarean, any surgery for that matter may also require. The other thing I was just thinking is it's very important to train them that sometimes, post-operatively, you do everything so well in the theater, and post-operatively when you are managing, the concentration, the focus is on the blood transfusion, because you keep thinking about the blood loss. But what happens, we came across a case where the junior was managing, the blood transfusion was going on post-operative ward, and suddenly there was they said the urine output is low and all those things. See, when you go there to the site, you find that they have been concentrating on the blood transfusion and the drop rate was so low, but they did not think of giving an IV fluid in the another limb. See, so small things like this need to be trained, because when you give blood, you take out that particular this thing and give blood in that vein. But what happens to the intake? It is also important that you monitor the fluid intake. The moment we rushed a little bit, of course, we should not be rushing too much, but suppose we rush a little bit of fluid in the other, this thing, immediately the urine output came on. So these small things, it is very, very important, preparedness wise and this wise. And thinking of whether we can have a center of excellence everywhere, I do not know. It's a big, big topic to be thought about at all levels, including politicians and the government, and probably the head of the Foxy to push it through.
Actually,
So
yes. It will be in the tertiary care center itself. It is all medical college. They have to have that mindset that this is the team for the placenta accreta. It is nothing. And what Dr. Gangadhar sir said, there is like in every obstetrical emergency, what sir has actually emphasized, the training for internal iliac, training for tympanoid, what we are actually teaching everywhere, reaching to small places as well, that how to do the tympanoid, how to do the dissection. That is the must, because it gives us confidence to deal with any obstetrical emergency, including the placenta spectrum. So thank you, sir, for sharing your experience. And Amrita, we sometimes really feel very good now that we have crossed that era, because I have also seen that 10 days no oxygen supply, and in Candle we did cesarean section, but thank
Yes,
God,
ma'am.
and
We
I
have done it
imagine
in
that
college.
there
Torchlight.
yes.
In Torchlight
Yes.
we have done.
see,
And open ether was there.
morbidity and mortality is a part of the practice, but then, if you show your commitment, just like how sir said, he left a note. See, he didn't sue him, he didn't punish him, he didn't criticize him, because he knew that sir has done with full commitment and devotion. So I think that expression that you are able to do the best under the circumstances, I think that is also a great thing, and that is where it takes. See, ultimately, whether the end result is good or bad is another issue. But at least you did your best possible under the circumstances. And I think that is what shows up.
Thank you very much. So, Ritu, thank you very
Yes,
much.
ma'am.
Thank you. Nice.
Ma'am, vote of thanks is, it gives me an immense pleasure to deliver the vote of thanks to all the dignitaries in this wonderful webinar. I thank our chief guest, Dr. Gangadhar Sahu, sir, who honored this webinar with his inspirational thoughts and such scary stories, which really made us also wait. And I thank our guest of honor, Dr. Milind Shah and Dr. Pragya Mishra, madam, for her gracious presence. And my sincere thanks to the speakers for their useful and brilliant presentation. I'm really thankful to the experts and chairpersons for their valuable inputs. And I'm thankful to Dr. Sadhna ma'am and Dr. Amrita Jaipuriar ma'am for their expert moderation and guidance. And I'm very thankful to the panelists who are very brilliant in their approach. And lastly, I thank the IT people for bringing out this successfully, this webinar. Thank you so much.
And thanks to you for conducting the session.
Thank you so much.
Thank you.